What we're going to be talking about in the next few minutes is an argument for or against clinical supervision. What would happen in your agency, in the world, if it didn't exist, and if it does exist, what are the benefits of it? So let's start with the benefits of it. Why is it that we have clinical supervision? Who wants to share first? And then I'll repeat it out loud for the camera. Yes, Gloria.
Without it, you can lose your direction as a new supervisee and not see things that could backfire and come back and bite you.
So we need direction in clinical supervision.
Direction and also the caring and the help.
Right, to be able to have the caring and the help and the direction of understanding various counseling techniques and increase and benefit our skill level, we need direction. All right.
Yes. According to the CCS exam, which I completed last year, it was a beast. The number one reason for clinical supervision is to ensure quality client care.
To ensure quality client care.
And I think public safety.
Thank you for that.
Mm-hmm. Ensure client care, and of course, do no harm. To prevent harm to the client or patient. Someone else.
Quality control.
Quality control. Say more about quality.
No, that's all I got.
Quality control. What are we trying? What do you mean by quality? Quality of what?
Well, I mean, as supervisor, you want to make sure that your supervisees are working in accordance with the statutes of the license and the ethical boundaries.
Right, that includes ethics within the guidelines, the statutes of our state. Yes?
And to build on that, it's valuable to recognize that as clinical supervisors, we gain something by having to see, like people talking about their children, seeing the clinical world through the eyes of their supervisees, I think makes us better clinicians as well.
Right, it makes us better clinicians, better supervisors, and the supervisees we deal with, it helps them to be better clinicians. So it's about the quality of care, and that quality can extend in a lot of different areas. A couple more before we move on. Growth and development. Growth and development of the counselor, the skills, the agency, our society.
So similar to that, like eliminate blind spots.
Yes, eliminate blind spots. What are some of our blind spots?
Countertransference.
Yes.
Codependency,
countertransference, projecting onto the client.
Self-care.
Yes. Some of our own self-care issues when we're burnt out.
Vicarious trauma.
Vicarious trauma, yeah. Listening to stories of our clients can cause us to be deadened or desensitized to the point, or overactivated to the point where we have our blind spots and aren't able to provide care. One more.
And along that same line, it reduces burnout with clinicians.
So good supervision can reduce burnout. Which will lead us into the next exercise that we're getting ready to do. So one of the things that I have seen and noticed in supervisees that I work with is how burnt out they are, how activated they are. They struggle with the number of clients that they're seeing, the number of assessments that they're doing, long hours. Some of them may be working into the evening, doing groups, that type of thing. And so by the time they get to my office to do supervision on Thursday and Friday, they're crackly crunch. So the first thing that I do with them is to help them emotionally regulate and to get back to baseline, to homeostasis, to calm the heart, to calm the breathing, to calm the mind and reset the whole system. And so emotional regulation is something that we teach our clients every day of the week, usually. And if not, it's something you want to start, because without it, it's really hard to recover from substance abuse and mental illness, because remaining in having a good baseline of calmness and groundedness and stability is hugely important for someone in recovery, because without it, if they stay activated, they're a lot less likely to stay clean and sober. They're a lot less likely to take their medications and do the things and everyday living skills that they need. So I'd like to teach you what's called the pretzel, or the hookup, in educational kinesiology. It is a great posture for calming the neurological system, which then cascades into every system of our body to create a baseline of calmness, centered, and groundedness. It's very simple. So how I teach it to clients, I basically tell them that the posture that I'm getting ready to share with them, or the skill, will really help calm their breathing and their brain activity, and will really help bring about emotional stability. It reduces anxiety. It will stop a panic attack dead in its tracks. So, and if you don't believe me, if you have panic attacks, give it a try. It's pretty amazing. So I ask them if they're open to learning that. And as soon as you say it reduces anxiety and will stop a panic attack, that you can see them get hooked at that point, because those are very devastating states of emotional dysregulation. So I'll say, are you right-handed or left-handed? And the majority will say right-handed. There aren't a lot of lefties out there, but there are some. So if you're right-handed, you cross and you do this seated, but I'll do it standing so you can see me. You take your right ankle and cross over your left. If you're left-handed, you cross your left ankle over your right. Then arms straight out in front of you, palms facing. We're going to turn our thumbs down, and then take, if you're right-handed, right over left. If you're left-handed, left over right. Lace your fingers, drop your arms down, and bring them up to your chest. Now, if that's not comfortable, you can loosen up and just cross your fingertips if you'd like. And if that's still not comfortable, you can just rest your hands down on your lap. But if you can hold this posture, it's very beneficial. So what we're going to do is 4 breaths, 4 very deep breaths. They're called extended exhale, because when we breathe in our nose and we blow out through pursed lips to really extend our exhale, it stimulates that parasympathetic nervous system. That parasympathetic nervous system puts the brake on the sympathetic nervous system, really slowing it down. So we'll start with a deep breath in the nose, and then blow out slowly through pursed lips to really extend that exhale. And if you're comfortable, close your eyes. If not, look down and soften your gaze. And then a second deep breath in the nose, and slowly out through pursed lips. Almost like you're blowing a candle out on the other side of the room. And a third when you're ready. And now just breathing normally and maintaining the posture and your eyes closed, or looking down and keeping your gaze softened. You can reflect on a pleasant or meaningful memory. Perhaps one of those things that you shared in our icebreaker about what makes you feel most alive. And just contemplate that over the next 2 minutes, and I'm going to count up to 120 seconds or 2 minutes, and then bring us out. And that it takes basically 2 minutes to reset the nervous system so that it resets all of the other systems. So take just 2 minutes to reflect on a pleasant or meaningful memory, and I'll bring us out in 2 minutes. And with a nice deep breath, when you're ready, begin to relax your arms down and open your eyes. All right. How was that? Good? All right. Kind of feel yourself settle in. Did you notice yourself taking that deep breath somewhere between 70 and 100, somewhere in there? Most of you, I could almost hear the breaths beginning to be drawn in. It's that final releasal where the body goes, oh yeah, this is what we're doing. We're letting go of all that tension. Everything that happened before I got here, everything I'm thinking about I need to do before the end of the day, and then the release comes. So it's very helpful. And so when you're doing clinical supervision, I encourage you to teach that to your supervisees. Practice it at the start. to kind of get them in their body, get them in the room, and at ground zero so they can then begin to talk about the various successes and struggles that they've had during the previous week. So one thing I want to bring to your attention, how many people are getting ready to take the CCS exam? Anybody? 3, 4, 5, 6? So you're probably wondering what to study. There's Ready to Test, which has a great study guide. There's also the Tip 52. The people who wrote that exam wrote this book, so this makes this a good book for really learning languaging and understanding, preparing for the exam. And the guy who led the committee who wrote that exam was David Powell, and this is his text. And this is, it's pretty heavy on content, but it's got a lot of good concepts in it. So these two together, and if you really want to go overboard, you can get Ready to Test, are great.
Is that the fact that they've recently changed the exam a little bit? Is that
They
still
constantly
recommended?
change it and add and subtract, but yeah, basically that's what they pull from. Yeah, yeah. And you can always, contact NADAC and ask them for recommendations too for study guides. It's a NADAC exam. It's not actually North Carolina Substance Abuse's exam. Yeah, good question. All right, so that Tip 52 also has a lot of forms in it. The whole back part of the Tip 52, Clinical Supervision and Professional Development of the Substance Abuse Counselor, has a lot of great forms in it. Now, you're probably saying, well, gee, Linda, I didn't know this was going to be clinical supervision only about substance abuse. No, we're going to cover supervision in general. But this is probably one of the best resources there is out there. It's for free. You can get it electronically from SAMHSA if you go on their website. And that means once you download it, all those forms are yours to use at no cost. So they're quite good. Everything from an individual development plan to consent for audio taping and videotaping, even a clinical supervisor evaluation form that you can give to your supervisee to complete. It has the 12 core functions in it and how to utilize the 12 core functions for developing a continuing education plan with your supervisee, because there may be some specific areas of study or of substance abuse functions that they're not comfortable with. Like they might say, I really am comfortable with group therapy and individual, but crisis assessment or crisis intervention, I'm not so comfortable with. And you might not think about talking about that if you didn't use that tool. So it's just packed full. Anyway, I thought we'd take a little gander through that. Moving on from the Tip 52 to supervision's role in substance abuse policy. I got a couple of calls over the last few weeks from various agencies really struggling with the number of folks coming in, smelling of alcohol, or them being notified that their counselor and or peer support, that kind of thing, was using weed on the weekend, or they were seen intoxicated at one of the local microbrews. And so when I get more than one phone call, I know it's becoming an issue. And of course, Asheville is known as Beer City now. And so does that mean that a person, even that isn't in recovery, can go down to New Belgium and tie one on and get silly? And the community sees that and is concerned about that. And or if their supervisor happened to also be there, they're like, how do we handle that? So I thought, well, let's just pull up some of SAMHSA's guidelines, because that's, again, if your agency doesn't have policy, it would be important to develop that policy. If they have a policy and they don't feel like it covers changes in culture and environment, then that would need to be revisited. So I want to just look at some of the wording, some of the policy that SAMHSA has. Under alcohol, the use, possession, or actually this is, I think this is out of Tip 52 actually, SAMHSA. So alcohol, the use, possession, or being under the influence of alcohol while on duty or on the premises is strictly forbidden. This prohibition precludes an employee from consuming alcohol at mealtime during work hours, even off of premises. And that's a question sometimes. Can a person go out and have a hoagie and a beer and then go back to work? And in some environments, some cultures, that's appropriate. It's not, I don't believe, for ours in this area, but that is appropriate in some places. So employees are prohibited from working with the smell of alcohol on their breath, regardless of when or where alcohol was consumed. Now, does that apply to them smelling like alcohol the next morning because they were up drinking the night before? Yes. And that, as a supervisor, I have run into more than anything, especially with young counselors, just, who still go out and party at night and that kind of thing. They come in the next morning, and that's not really a good thing to do, whether you're a substance abuse counselor or not. But just keeping in mind, and you don't have to fire somebody for that. They may not just be aware of it. To talk with them about that, to create an action plan around that, or a plan of correction is important. Drugs, the use, possession, being under the influence of manufacture, sale, dispensation, or distribution of illegal or unauthorized drugs or drug paraphernalia while on duty or on the premises is forbidden. So again, that covers not just alcohol, but substances. And we'll kind of break that out in a few minutes to also prescription medications. Got a call a few months ago from an administrator in an agency who said that it had been determined that a counselor there's husband was dealing weed, and they weren't sure what the parameters were around that. So we talked about it, came up with a plan, and they were going to talk with that counselor that had been reported, and that was totally unacceptable behavior, and that it did reflect on her and her work there. And they did that, and she quit. So that was a clear statement that she wasn't willing to make those changes in her family life or in her family. We had here last year someone give the example of going to a Christmas party, a company Christmas party. I think this was down around Charlotte. And somebody lit up a bowl, and it was her supervisor. Again, being very concerned about, and she was told not to, that what happens in their social life doesn't reflect on the business. And then as that person got to talking, that was the owner of the company. So I think that was, again, setting a precedent that wasn't appropriate, certainly unethical. And I think because they were the owner of the company, maybe they thought that would fly, that they could set their own policy around that. Just when you thought you'd heard it all, that was one that really surprised me but didn't. So, cannabis is very, depending on the culture and the population, can be equated with alcohol. And if alcohol is legal, then why can't I use weed? Yes.
I've noticed that since the legalization of marijuana in some states.
Yes, there's more of a rise of that. Yeah. Anybody else notice that as well?
Yes.
Yeah. That if it's legal in other states, then we should be able to utilize that here. So if fitness for duty, employees are required to be fit for duty. An employee is unfit for duty if while on duty or on the premises he or she is under the influence of or affected by illegal or unauthorized alcohol, and that includes prescription drugs as well. If a person is using prescription drugs and they appear impaired or unfit for duty, that needs to be addressed as well. Even though it's prescription, it doesn't mean that person needs to be present impaired. And I've run into quite a bit of that over the years, where someone will have a death in the family or divorce or things are happening and they begin to use benzodiazepines. And they use those to the point where they have the slow head movement, eye movement, slurred speech, and coming in. They don't notice it. And of course, benzodiazepines are very addictive. It takes more to be able to deal with their anxiety because they develop a tolerance for it. So they may not know it, but certainly that's a part of supervision, is being aware of that and monitoring it. So this gets even more into a little deeper about testing and that kind of thing. Reasonable suspicion. An employee may be required to submit to drug and/or alcohol testing whenever there's a reason to believe, because of physical, behavioral, or performance indicators, that the employee is under the influence of or is affected by illegal or legally prescribed drugs and/or alcohol while on duty on the premises. We actually had a psychiatrist, one agency when I was working at, and we kept noticing he seemed a little off. Behavior, just kind of dropping the ball on things, not good eye contact, a little bit of slurring, but not enough. You know, you just want to give him the benefit of the doubt, right? And we knew that he was in recovery. He didn't tell us, but we knew from the community. And of course, the agency director needed to talk with him about it. And he did admit he had had a relapse on opiates and went into treatment, but did not come back to that agency. So, you know, we want to think sometimes that we don't want to bring it up with individuals because they might deny it, and then we've got to prove it, and that's a whole HR nightmare and all those things. But that person may be ready to get the support that they need and may be ready for treatment. So it was, strangely enough, that particular psychiatrist we'd all gone down to Raleigh. We were working on some kind of certification at that time, and he had been driving back, and we noticed him kind of swerving. And, you know, again, our director said, you know, let's pull over and get some snacks and get some Cokes and stuff, and then she took over the wheel because she thought he was just sleepy. But again, those moments when I think I could have lost my life because someone didn't want to pursue it, didn't want to deal with it, didn't want to talk with that person about behaviors. So don't let it go on too long. One other quick story. A woman about my age had come in. She was going to be the clinical director, and Jolene will remember this. But I kept noticing really strange behaviors, like she seemed confused. I would give her a tour of the building, and I'd walk out the door, and we'd head down the hallway, and she'd go in the opposite direction. And I go, hey, you know, we're going this way. And showing up late for work, struggling to get a urine screen. There's a big one. And that was a huge, long story, too. Always an excuse. But anyway, one day she had lost her keys, and she asked me to help her find them. And I thought, well, that's interesting. I said, well, is your car locked? She said, no. And we went out to her car looking for them, and I saw a blow and go. And so that was a first clue again that, you know, she may have relapsed or whatever. But anyway, the final piece for me is we were sitting in a staff meeting, supervision, and I noticed her almost stumbling that day. And she got up to go use the restroom, and she had a styrofoam cup there, and I lifted up and smelled it. And it didn't have alcohol in it, which surprised me because I kept thinking is she drinking on the job? But what we discovered, HR began to talk with her and work with her, is that she was drinking into the evening. She was staying sober in the daytime on the job, drinking in the evening, but she was drinking so late that she couldn't do the blow and go, and that's why she was showing up late for work. But she clearly had a relapse and needed help. So again, not to pathologize, not to think that we're always going to get resistance, but to be very matter-of-fact, calm, grounded, centered, and talk with employees and supervisees when you see behaviors, and be specific. I mean, nobody likes this kind of stuff, right? It all makes us not want to, have to talk about it or work with it. But people can get harmed by that, and as we look at the board over there, it says do no harm. And that means being vigilant about supervisees and staff who may present impaired in some way. So post-accident, an employee may be tested for drugs or alcohol after any accident that's been caused by human error or carelessness. An accident is defined as an event resulting in medical treatment by a professional or property damage of excess of $500. Most liability companies, if you are an agency and there's a car bump up or something, even if you back into a telephone pole or run over a trash can, they'll get you tested because, and if you're a weekend warrior and you smoking weed or you drank the night before and that's in your system, it's going to show up. And then that's usually a referral to EAN. It's not an immediate dismissal, hopefully, but to help that person understand that while they're in a role of a counselor, peer support specialist, or in this mental health field, that they need to not use illicit substances. And to certainly, if they tested positive for like a benzodiazepine or an opiate, they would then have to present a script to confirm that. And then levels also could be done to see that they were within the appropriate blood levels for that prescription. Medication control, if prescribed medication or controlled substances is dispensed by the organization, they disappear or cannot otherwise be accounted for, such as what we call diversion, medication diversion. All employees who may have had access to such medication or substance will be tested for illegal drugs. Now, if you have a no smoking policy and somebody's vaping in the bathroom or in another room of your building, does this cover that as well? Yes, it does. Yeah. Okay.
Same thing about coming in, smelling the smoke too, because that can be a trigger.
Yeah. Coming in, smelling of smoke. So supervisor's role in substance abuse, again, what happens if you get a positive test result? An employee who tests positive for an illegal drug or unauthorized or illegally obtained legal drug and or alcohol is unfit for duty and may be disciplined at that point. Hopefully there is a recommendation or referral for a substance abuse assessment, and then recommendations and follow through for that. So drug-related convictions, an employee who's convicted of a drug-related offense occurring in or out of the workplace is in violation. A conviction including a guilty plea, a plea of nolo contendere, or any other court-supervised program or court-imposed sentence. So again, many facilities will allow a counselor or someone to continue to work as long as they are in treatment. Some will want them to go to treatment and test clean before they come back. Bless you. Searches, the organization reserves the right to search an employee, his or her possessions, work area, or vehicle while on the premises to determine if illegal drugs or alcohol are present. So you can see, a lot of this we don't even think about, but it's really important to make sure your agency is on board, or your private practice or whatever, to cover all of these areas. And failure to cooperate, that's happened once in my whole career, where a CSAC, a woman, failed to cooperate. She did end up cooperating and did test positive and received counseling and came back to work. But that failure to cooperate was, I have the right to take as many medications as I need to take care of my migraines, to take care of my anxiety, which causes my migraines. You can kind of hear that languaging of entitlement and minimization and denial. So an employee who refuses to provide a specimen at the date and time requested, who refuses to provide a written consent to testing, who provides a false or tampered specimen, or refuses to consent to a search of his or her person, possession, or work area, can be either dismissed or, dismissed. And North Carolina is a no-cause fire state. Do you know what that means? Mm-hmm. It means you do not need to have cause to release somebody from their employment. Does it mean they can't still come back and sue for, missed wages or whatever, but it is a no-cause fire state. Yes?
Your comment about the employee who says, I have a right to take prescribed medications for a psychiatric condition.
Yes. And yes, they do. They just don't have the right to be impaired on the job or unfit for duty. Yeah.
You're not going to run afoul of ADA if you can cite that they're impaired in some way as a result of those.
Yeah, all of this is about documentation and working closely with human resources around that, because they're very up to date on or aware of the laws and policies and procedures around notification and dismissal and all of that. So the main thing is just start with what you see. What's going on? Checking that out with the person. And if they go straight into denial or become defensive, you guys know what's coming down. And then you've got to approach HR and say, this is what I'm hearing and seeing. I'm handing this over to you. Because then that says they're not workable in that supervision environment. But still, if you expect someone's impaired, to notify HR and then for them to follow appropriate company policy. I would say 9 times out of 10, when there is an impaired professional, the company they're working for is not prepared for that. Their policies aren't up to date, they're uncomfortable in dealing with it, and so don't let your agency be one of those agencies that's not prepared. Ask HR, ask, can I see the policies about substance usage or impairment? And know those so that you're well prepared.
What, if any, is your responsibility as a supervisor out of an agency?
So you carry complete liability. I mean, once you sign that contract and you're their supervisor, you carry a vicarious liability. That means everything they do, you are responsible for knowing and addressing. So yeah, even if they're not in an agency. If you're an independent supervisor. Yeah. And in fact, that falls under ethics with the Substance Abuse Board. It talks about, nobody should be impaired or unfit for duty. And if so, it should be addressed immediately and or the board notified. All right. So like if somebody goes out and gets a DWI and they're a CSAC or an LCAS or a peer support, what happens? Does the board find out about it? Not necessarily. Not unless you tell them. So yeah, that's it's our responsibility as a supervisor to notify the board that we're supervising them for. Like if you're a CCS, then you notify that board. If you're LPC, notify that board. If you're LCSW, notify that board. Because then if you don't, you can be held liable for that if they do harm.
During the research, though, you don't have to, but there's that, have you had any convictions? Have you had any treatment?
Yeah, you're talking about research on what specifically?
On any license, yeah.
I don't know. I don't know that I've seen that on mine, but it might be there. Is it? Oh, is it online now? Okay, yeah. I must have checked no and moved on. Yeah. So when a person recertifies, there is that question there on your recertification application. Yes, Don?
And I'm fairly certain that the verbiage is, have you been convicted of any felony convictions? Okay, and contrary to popular belief, unless you're a habitual DWI offender, DWIs are misdemeanors.
They're not felonies. Yeah.
So you can check no.
If it says felony, yeah. Does it say felony? Anything. One she's talking about is any, misdemeanor. Okay.
Did you say you got the verbiage that was up there from SAMHSA?
Yes, from tip 52.
Oh, it's
right here. It's in here. Yeah. It's right there. I'm telling you, this thing's like the Clinical Supervision Bible. If you don't have one, you need one. And you don't have to get it written. It's all downloadable. And so some of this will be a review to some of you. How many folks were here for the last Clinical Supervision? So a little bit less than half. So about half are new, half are not. So some of this will be just a quick review, and then we'll move forward. Methods of clinical supervision, again, recorded observation versus videotape. If you're an LPCA, that's mandatory. You must have one of those for every 40 hours. It is optional for LCAS, CSAC, that type of thing, or LCSW, right? LCSWs don't have to have recorded. Live observation is the best, but unless you work in an agency where you're supervising the folks, that's not going to happen. Of course, if you want to, and then moving on to audio taping, and there's consents for those in the tip 52, which are nice. And you can just tailor those based on your independent and your individual situation. Verbal reports, again, that's reading their notes. Verbatim reports where they're actually dialoguing something, written file review, case consultation, and that's typically what we use the most in case presentation, that we're actually having them go through an outline, and we'll revisit that in a few minutes, of a case presentation. And there's some nice case presentation formats in the tip 52 as well. Webcam, bug in the ear, co-facilitating or modeling. That is the most fun ever, to be a part of that group and to be with the supervisee working with them. And then, of course, role playing in your office with supervisees. I've been doing more and more of that lately, especially like empty chair is really fun to role model or for them to experience to use with clients. And that's a Gestalt technique, empty chair. Questions or thoughts about methods of clinical supervision before we move on? So again, going through that first clinical supervision session, really describing your role. Because many people may have never been in supervision, or they've been in supervision when they were in college, and now this is very different. And so describing your role, who you are, your philosophy of supervision is really important. I think the people's reticence to bring audio tape is that they're embarrassed and they feel like they might be judged. So really just helping them understand that audio taping is a great way for them to learn from hearing themselves. It's not really anything that, there's no judgment in that. It's just listening and learning from it. And typically after I listen to a tape or an audio tape of one of the LPCAs that I supervise, I always ask them, what did you hear that you felt you did well with or want to do more of? And what did you hear that you'd like to do less of or you would have done differently? And for me, that's a growth moment. They're able to see that, hear that, or just hear that and then talk about. And really one of the things that I hear a lot of feedback on is, I say too much, like or and I'll say, so that's just filler. And I think that'll go away the more you get comfortable with that client. And it does. 9 times out of 10, it always falls away. So again, that really describing your role as a helping person, not as a person that's judgmental. And I usually tell them, make the first tape you bring in something that's with a client that you really feel good about, that's making progress. Don't bring something in that's a difficult client unless you particularly want to. Bring something in that really helps you feel like you have done a good job. And that's really helpful, giving them that up front. And then bring in your most difficult borderline personality disordered client. And that'll be fun to work with. And then you can talk about how to structure. The first thing you might hear them say is, well, how are you doing today? Well, if you ask someone with a personality disorder how they're doing today, they will really tell you in ways that's not real productive. So how might we then start the session with, let's talk about your homework that you worked on. And if they didn't bring their homework, so tell me did you do some of the assignments and what did that look like? And so it's highly structured. So there's not a lot of feeling statements. And not a lot of emoting. It's very cognitive behavioral. So when you describe your role as being non-judgmental and you talk about audio taping or other means of supervision, being very encouraging can be helpful. And I always tell them, you can bring in a minute, 2 minutes, 3 minutes, 5 minutes, 10 minutes, 15. It's up to you. The tape is for you to be able to learn from, not for me. I'm here just to hold the sacred space of you listening to it and making some decisions about what you want to do different or more of, and to just interject something like, if you've got a very difficult client, structure the session so that there is less resistance and kind of more compliance. All right, complete disclosure statement, and some of you guys that may be required by your license or not, but that's really important. In LPCSs, we're required to do a disclosure statement. If you're an LCSW and you're supervising an LPCA, I highly recommend really looking at the policies and how to set up that supervision, because it is very specific and does include that disclosure statement. And if you ever get a complaint filed against you by that board, they're going to ask you for that disclosure statement up front. And I know that by experience, so make sure you get that disclosure statement. And there are disclosure statements also in the Tip 52, kind of what to expect from supervision. Describe your model of clinical supervision. Talk a little bit about your supervision format, and what I like to talk about is case presentation and processing and working with those cases. all the way to me teaching something like motivational interviewing skills, or looking at different CBT curriculums such as gender-specific substance abuse CBT. So being able to talk with them about your model of clinical supervision and what you have to offer. I always talk about contemplative supervision, which was coined by David Powell and is talked about in this textbook really nicely. And one of the ways that I start supervision off that's contemplative is with the pretzel posture and deep breath work and that kind of thing. Usually what I do is when they pretzel up, I ask them to think about, over the last week since we last met, just think back about any struggles that you have with clients and any successes so that you can bring those forward when we come out of the pretzel. And when they come out of the pretzel, they always have that right in their mind, which really, again, helps them zoom in on what's important. Because you got less than an hour, right, to work with someone who's just seen clients for 40 hours or that type of thing. Okay, discuss methods of clinical supervision. Begin to explore the supervisee's goals. And that's where the questionnaire that leads into the individual development plan comes in handy in the tip 52, because it covers all 12 core functions of a counselor, not just substance abuse counselor, but a counselor. And once you go through that, then they'll be ready to identify goals. The other thing that I think that makes me feel most alive about being a supervisor is when I have a supervisee who doesn't have a lot of money and they want to go to a conference. And they don't know they can apply for a scholarship for that conference. And that scholarship is dependent on your recommendation. You're recommending that supervisee. And when you do that and you read that to them or give that to them to submit, it's a very powerful, affirming, and validating moment. So think about the supervisees who really could benefit from some of the conferences statewide, and look at the scholarships that are available and get them scholarshiped in. It's very helpful. And it really is affirming to them. Differences in supervision and therapy, and we'll get into that in a little while. I've got a slide that divides the two. And David Powell, I think, would say, so what's the difference between supervision and therapy? And he'd say, not much. He would use the example of, oh, your mother recently passed away and you're working with this client whose mother just now died and you're working with grief. So let's take a look at that. And he would explore that with them. He would say, so your mother passed away recently and after a long illness and you had cared for her. Where are you with that right now? And then when they describe, well, I still cry every Sunday when I think about calling her. I'm not sure I could work with anybody who has had someone who's died recently because it's so fresh for me. Then he would say, okay, the difference between supervision and therapy is the supervisor would refer them to a grief counselor, and the therapist would begin assessing them for the level of grief or where they are in their grief. So just being aware that it's okay to ask about and know what's going on in the life of our supervisees. We just don't want to move into the counseling arena. We want to move into the referring out. Now, here's David Powell. Really, he was so awesome. I wish he was still with us. To learn under him was just magical. And he had a great sense of humor. He would say, so let's say you're teaching a technique, a counseling technique, to a supervisee. To teach that counseling technique, chances are they're going to have to come up with an issue. So he would say, if you're going to do that, make sure it's an issue that they're kind of done with, that they've dealt with. Let's say like the death of a loved one, or what's something else? A divorce? Well, let's say, possibly a divorce. But let's go in or a supervisor that they had, that they weren't able to use their voice to talk about what their needs were, something like that. So if you're going to teach a technique, keep it contained, keep it about issues that are not emotionally volatile or powerful for them. But he wasn't against doing peer work between supervisee and supervisor to learn actual counseling models. He said it's best if you can do that in a group where you divide them up into twos and they teach one another. But certainly you can teach counseling techniques to supervisees. He said just keep it, what was the word he said? Keep it between the lines or something like that. So again, there are areas of gray, and we need to be very vigilant that when we move into gray areas, which brings us to ethical guidelines here, but we're going to take a bathroom break here. But a couple of the ethical guidelines I saw had that gray area. What happens when a supervisee invites you to her wedding? What happens when a supervisee and you are of the same home group, in AA or NA? David Powell says better switch groups. But you're talking about some supervisor that might have been in that home group for 25 years. And this new supervisee comes in, is she going to say, no, you can't come to that group? So when you start getting into the recovery community, you see some of those gray areas. One time I was teaching and I asked the question, so if you're at a AA or an NA meeting and you're in recovery and you're a supervisor or a counselor and you look out and you're a speaker that night, let's say you're going to tell your story, and you look out and you see a client sitting in the audience who has borderline personality disorder, what do you do? And so it was really interesting because, just tossing that out, part of the group said, I'm telling my story. It doesn't matter. I'm not a counselor there. I'm not this. I'm not that. And so this guy was really vehement. He actually was standing up kind of blowing saliva out. And then the others were sitting there like horrified at what he was saying. So that was his experience in his culture and what he knows. And the others would have said, no way would I've told it, because that would have possibly done harm to the client and me and our relationship. So I would have really shifted gears and moved to a step meeting, or I would have done something else. But so nobody's going to be there to tell you what to do. Nobody's going to be there to tell you what's right or wrong, right? It's up to you, and that's why we have these trainings, so we can talk about this and think about it and come to terms with some ideas about what you would do, so that when you're in those situations, you've got something to draw from and to pull from. All right. Any questions before we take a break about any material we covered so far? Love those gray areas, don't we? If I can remember, I'll tell you one quick David Powell story, and it was an Asheville story. He had a confrontation with an Asheville counselor that day, and I thought it was interesting. So take a break for 15 minutes. If you smoke, don't inhale. We'll meet. Look through a few of the forms that are on in the tip 52 to kind of titillate you to want to get on SAMHSA and download that and utilize some of the forms that can really make your life very simple and give it structure in your supervision. Just highly recommend it. So the first significant notes about that supervision is hugely important. So I'll have to tell you the short David Powell story. So I guess I was living in Black Mountain at the time. I think I was working at ADAC maybe, and we had several of us gone down to supervision training with David Powell down at Chapel Hill, and I don't know, there was probably 75 of us in the room, and he was talking about ethics and guidelines and boundaries, and he said, so he had some case studies that he read off that we were discussing. He said, so you're a counselor that does home visits. Let's say you're on an ACT team or something like that, and you go into the person's home, and they see that you've got a wedding band on, and they say, are you married? And he said, so how would you answer? And most of them are like, well, if you got a wedding band on, you say, yes, I am, thank you. Then what if he said, so he kind of like, nodded his head and looked at us a little strangely. Then he said, so, you could tell he was going to make a point here. He says, so what if they ask you, where are you from? Who are your parents? Or questions like that. And of course, everybody's sitting there afraid to say anything. And there was this wonderful social worker from Asheville who said, well, I'm going to tell them who my parents are and where I'm from. And David said, well, I'm not sure that's the best thing to do, because then that makes it about you. And she said, well, let me tell you something. In the mountain culture, if you don't answer the question, you won't be there very long. And I loved that moment, because the piece that David had missed was the cultural context. We really have to consider the cultural context. And I'll tell you, when I was BSW social worker, I'm working in Yadkin County, which is where I'm from, I spoke Spanish. And so I was going out with some home health workers to the home to interpret. And she said, let me stop by this other place, check this guy's blood pressure, just check on his decubitus ulcer, redress it, and then we'll go right back. Well, of course, we go in, and the gentleman's laying there in the bed, and he knows the nurses. He doesn't know me, so he looks at me and says, who are you? And I told him, and he said, who's your people? And I told him, and I will never forget the look on his face. He had known my father, and he said, you look just like him. My father had died when I was 5, and had been, they were very, very poor. They weren't even tenant farmers, didn't wear shoes kind of folks. And he told me all about my dad, which was pretty powerful, being I don't have a lot of memories about my dad. And how I knew he wasn't jerking my chain is he called my dad by his nickname. He said, oh, you're Sant's, S-A-N-T, Sant's daughter. And my heart just leapt. So, you know, I made a special visit out to him with the nurses more than once to be able to talk with them and to hear about my dad. And it's one of those moments where it made him feel alive. There he is, terminally ill in the bed, decubitus ulcers, high blood pressure, diabetic, not doing well. And for that moment when he talked to my dad and he knew that my dad had died, what he could share with me really woke him up and made him smile and laugh and tell great stories. And the nurses were just marveling, over that kind of thing. But that's one of those magical moments. I'm so glad he said, who's your people? And I was able to say. So, cultural context. So moving on to develop relationship, how do you both balance work and leisure? Talk about upcoming conferences and scholarships. So, just like I started off our icebreaker this morning, what makes you feel most alive? And I wish I could have gotten a snapshot of each one of your faces, because everybody's kind of straight-laced and, not smiling a lot. And when you said what makes you feel most alive, you smiled. And that's called resourcing. It resources the pleasant or positive memories in ourselves. And doing that with our supervisees. I encourage supervisees I work with to develop workshops and teach. And 2 of them are teaching. Only Jolene, you're not under supervision anymore. But Jolene used to be a school teacher, so I know she has it in her. And I've seen her teach at Mission. And in fact, I never told you about that guided relaxation you did one time with us. I forgot what you were teaching. It was the best one I have ever had. I mean, I dropped right in really fast. So.
I have no idea what you're talking about.
Yeah, it was up in 4403. What did you teach? You did a guided imagery and a progressive relaxation. Do you not remember it? It was like last year. What did you teach?
The borderline.
That's it. Yeah, for borderline personality disorder. Wouldn't that be a great thing to use with folks who are activated, is that guided imagery relaxation? But anyway, I just noticed some people have a very calming voice. And the thing that worked well that you did is when you had us breathe in between the different steps of relaxation, you were silent. And that silence is very powerful to drop in. So develop a relationship. Really, again, what do you do for fun? What makes you feel most alive? Helping them get scholarships, discussing legal and ethical implications of clinical supervision, and consider a walk-in clinical supervision if you live in an area that's fairly private. I highly recommend that. I mean, everybody's got, your butt's wore out by the end of the day. You think yours is, the supervisees as well. And to find a section to go walk in. When I worked downtown and had supervision there, I was across from the Episcopal Church, and they had the most beautiful garden there, and in the springtime it was beautiful. So we'd walk around the block a couple times and then would finish up by sitting on the bench, which was like a prayer garden, so it was very removed and quiet and private. And I'll never forget just sitting there and doing the pretzel and listening to the birds. And the wind blew, and they had some roses in the garden there, and to smell that was just very powerful. So walking supervision can actually be a form of ecotherapy for both of you. All right, so we'll stop there, and then I'm going to read a couple of ethical concerns. Supervisee who continues to invite me to social and other events even after ethical boundaries have been explained to her. Some people need it more than once. And what do you think she's trying to say if she keeps inviting you? You're that important. It would mean that much. And so being able to say, I'd really love to come, but until we're out of a supervision relationship, I'm not going to recommend it. I'll have to tell you, living in the small community that we live in, I knew a supervisee, just casually, because, many of us are bachelor level social workers and we go on and get our masters and go on up. And she and I had worked together at different times in our lives as BSWs. When she invited me to her 40th birthday party, I went because we'd had a previous supervisory relationship and we had finished our supervision, but it had only been a couple of months. But I knew what it meant to her. And so I did go. I didn't drink with them. I thought that was important. But her family was there and got to meet her family and her nephew and everyone. So again, when it's ethics, it's really important. Who's the holder of the right of confidentiality there? The supervisee. So I felt comfortable with that.
It can also indicate, in the devil's advocate, that she's not feeling connected with the supervisor, and she's trying to make a connection.
Right. So to meet her outside the supervisory relationship, she may not feel connected to her, and she's trying to create a connection. True. Very good, Yvonne. Supervisor not having adequate time for all supervisees due to just time constraints. If you don't plan it and put it on the calendar and show up, it'll never happen. So really hold that time sacred. And do group supervision if you can't do individual. Save individual for that time when you need to cover something that's more private. Well, let's say when you're in group supervision and somebody says they're starting to work with a sexual abuser, but they've never done that work before. Well, we don't always embarrass them right in front of the whole crowd and go, well, if you've not done that work before and you've not gotten training, that's out of your scope of practice. We might want to pull them aside in individual work and talk with them about that. And say, you may not be able to do that work now, but work on the training for it. Supervisee who does not keep to the schedule and doesn't show up. Well, that's not going to work. That's your liability. And I tell you what, you better make a note, not you better, I better make a note that says, supervisee called, can't come due to lack of finances. That's the excuse I get the most. I can't afford it this week. Well, if you're working, you can afford it. So and I'll let people put payments off. I mean, I'm not cruel. When a supervisee isn't meeting standards, is ethical, legal, but isn't able to implement good counseling skills, which start to create an ethical issue of possibly not being beneficial, what to do. Also, I mostly work with interns, not LPCAs, and is that different? It is and it's not. So if they're still in school, you want to probably talk with their school supervisor about that, if you're seeing a lack of skills or any issues or concerns. Now, if they're an LPCA or LCSW and you're responsible for them, then it's time to really put some structure in that supervision, do the assessment and the individual development plan, and get them sent off to some workshops and practicing some skills. I'll be honest, young supervisee that I had come through a program, LPC, she wasn't LPCA yet, but she said, I just don't know the difference some days between a conversation and counseling. And I just said, that's okay. Let's talk about that. And got out the whiteboard and talked about the differences and how to put structure in and how to choose a CBT curriculum to utilize with that client. So it wasn't, she was just underwater. She was overwhelmed. She was in school, working as well. And so she just needed that help, that structure. Some days I don't know the difference between the two because the client comes in and just starts, talking at me, and I can't even get a word in edgewise. So really saying, let me stop you just for a minute and share with you what I heard you say, and I have some things that I'd like for us to work on today, and put the structure in. If not, they just come in and emotionally dump, and they feel better, so they leave, and they think that's counseling because you didn't intervene, right? The counselor didn't intervene. Then they come back the next week. What did they do? They come in, they emotionally dump, they feel better, they leave, and you're a wreck.
And then when you do try to implement structure and provide homework assignments, they stop coming.
Right, and I go back to that's true because they wanted to just come in and emotionally dump.
Yes.
And that's not counseling. And if we allow them to do that, when we're enabling, and that just keeps them activated. Michael Garrett, who was a Cherokee gentleman who from the res up there and taught at Western, he had this great phrase. He said, they get what they come for. They get what they come for. The question is, are we able to slow down that process and help them get something richer than just what they came for? And I go back to that statement often, very powerful statement. Are we able to slow down that process and put the structure in that will help enrichen that counseling experience so they can get more than what they came for? Ethical concern. Can't read that. All right, that's some fancy writing. A client in prison says he's using. Do you break confidentiality to notify custody? Boy, that's a whole nother set of rules. Yeah. I would start off, I don't know. I don't know what the law, there's probably some laws around that. But what I would say as a substance abuse counselor, I would work with them around that substance first, because prisons are always going to have substances. There's no way to stop them from coming in. Unless they just stop the visitors and plug up all the mouse holes. I don't know. But the substance abuse counselor would want to work with him first about how's it helpful, how's it hurtful, what do you want to do different, that kind of thing. Do you know the answer to that question?
We've actually been compelled to let custody know because fentanyl and
overdoses, and fentanyl coming in and killing somebody. Yeah.
Wanting to get a handle on it before somebody passes away. So.
Yeah.
But I think if you focus on that treatment and build that rapport, maybe you can get the client to a point where they would be willing to do that with you.
Yeah.
That would be good if you're in private practice or doing it outside, but in the prison system, the law is if you don't report it, you then are an accomplice to that legal crime.
That's what I was wondering, yeah. Yeah. So in the prison system.
I thought it was a neat ethical dilemma.
Yeah, it is. It is. As a substance abuse counselor, it is. Because, that substance abuse counselor is in the DOC, but also, so what follows there is the laws apply first. If it's a breach of law, then you have to follow the legal. Then it comes ethical. And when it comes to ethical, it has to do with the highest ethical standard. We must follow the minimum of the legal and the highest of the ethical. Yes?
Before you ever start with these people, you need to inform them of the limits of the confidentiality in the system they're in.
That's right.
So before they give you that, you have to tell them, look, I have to report that. That's part of my job here. So,
Yeah.
I cover it during orientation so that it's not an issue. I stress confidentiality, and then I give them, these are the ones we have to abide by
that are actually legal. Inappropriate self-disclosure with a supervisee regarding their own mental health issues. So if a supervisor shares their mental health issue, where is that? What is that? Is it appropriate or inappropriate self-disclosure?
With the supervisor?
The supervisor with the supervisee. So let's say the supervisor suffers from depression, and so does the supervisee, and there's disclosure there. It can be appropriate and it can be inappropriate. It just has to do with the situation. Yeah. I think the same rules apply. It should be something you're done with or you're in a stable place with, and once you share that disclosure, you put the focus back on the supervisee. Yeah. All right. Counselor providing support for a specific diagnosis and is faced with a co-occurring issue outside their scope of practice. So anytime that we're looking, well, like let's say you're a substance abuse counselor and you're a CSAC, and suddenly you get someone with trauma. Can you treat that trauma? Not unless it's in your scope of practice. So that's, again, the jury's a little bit out on that, and I don't want to get too deep with that. But if it has to do with the trauma around their substance abuse, my understanding is it can be treated if that person has that training. So issues that are directly connected with the substance abuse. Hearing about questionable ethical practices in a program from supervisees. So what do you do when you hear about questionable ethical practices in a program, an agency, when you're supervising a supervisee? What do you do with that?
I like to empower the supervisee to follow the chain of command. If they're not able to, depending on what the issue is, then I would address it.
Yeah. Yeah, follow that chain of command in your agency and talk through it. Tell me a little bit about that ethical issue. What are you hearing and seeing from that supervisee? Let's brainstorm this. Let's work on it, because it's a teachable moment. That's what supervision is. They're bringing to you what they're struggling with, and then following that chain of command. So guidelines for giving feedback always begin with what went well and how the client responded. So that gets into a little bit about sandwiching over there, 2 positives for 1 negative. Always elicit their self-evaluation first. They will usually notice something first. So as you share that with the client, share with me a little bit more about what that was like for you and how the client responded. And did you get the response that you were wanting? So making it very timely, 2 positives for a negative, which is sandwiching those. What would you do differently, if anything, or more of? And never evaluate the supervisee in front of clients. I mean, that happens from time to time. I don't think they mean to do that, but typically I see that or have heard about that when you're in a group therapy situation with a supervisee and you're kind of co-counseling, running that group together. It's really important to remember to intervene when you are about to see that harm is going to be done. So if you are in that group setting and well, I'll give you an example. I was out west. I'd contracted as a clinical director for a large, not a large, a pretty big size inpatient therapeutic kind of boarding school. And one of the women there was a substance abuse counselor in recovery herself. She had just come from a prison into the Texas prison system. And she was doing scream therapy. And she had them all sitting on the floor. And she crawled over and got this far from one of their faces and started screaming out. I was sitting there. I thought I was on the wrong planet. I was in shock. It took me a moment. And I thought, if she does that in front of the new clinical director, I'm afraid, I wonder what she's doing when no one's looking. And that was the therapy that she used. And I mean, she was literally spitting on the young girl's face. And I saw her completely dissociate, just shut down. And I said, whoa, let's take a break, and pulled her out. And she was like, what? How dare you? And it works, and it's evidence-based. And I said, no, it's not. If somebody evidence-based that, I'd like to see the research, and I will tell you, I don't care what the research says. That's not appropriate. It's unethical. And the young woman was terrified. I said, if she wasn't craving before she came in the room, she's craving now, because she's activated, very activated. And so she really took that all the way to the top, that counselor, and was eventually released. But yeah, there's those therapies still exist, folks, still exist out there. So anytime when you see that harm is about to be done, it's really important to step in immediately and prevent that. Yes?
There was an intern that worked for a particular agency, and the doctor who was supervising the intern had her go. I mean, clients had been complaining that, that they couldn't relate to her, that she wasn't connecting with them, and the first time ever I heard the term resting bitch face.
What? Rusty bitch?
Resting bitch face.
I've never heard that. No.
My bitch face never rests, it's always on duty.
Okay, this is good. I like it.
That means she looks angry when she's
Resting.
not right.
Got it. I love that. I don't know that I'll use it, but I like it. I know the person. Okay.
But anyways,
Cut that out, John.
She had her go before the clients and have the clients each go around and say how they felt about her and what she gave off to them. Do you think that's a good strategy?
Oof. No. I don't think it's real fair to her. What it tells me is she's got trauma, probably, and that would just activate her trauma. And that kind of puts them in power and control, and I think that is, I get it, and it may have worked, but it may not, and it could have created resistance and a lot of shame. So I would have just worked with her first about her presentation and what's happening inside her, and I actually have had a male supervisee that had that syndrome, but it was more blank than being almost blank to horrified, almost like don't know what to do. I don't know how to help these people, getting overwhelmed. Had not had substance use issues himself. And for him, what ended up coming out is those people are all entitled. He was still stuck into substance abuse as a moral issue. So you kind of see where that counselor isn't bad or wrong. Their training just didn't happen. They didn't make the leap between the moral issue and the biopsychosocial disease process, the biochemical disease process. Saw those people as, and it was high-end clients, wealthy clients, saw them as all entitled and special. And of course, there was a couple of narcissistic folks in there. So what ended up being is just helping him work through that. And it wasn't a good fit at that agency, and he did change jobs and loves his job now and is doing great. Perfect supervisory issue. Yeah.
I had early on in counseling, in group therapy, a couple of people asked me after the group why I was staring at them. And there was no supervisor in there to say what my face looked like. So I went home in the mirror and closed my eyes and put on a real intense listening face, which I have when I'm listening. And it looked like I never heard that term, but it looked like a resting bitch face. So I had to consciously
soften your affect.
I looked like I was.
Yeah, exactly. I saw that face. You just made it. It's like, it's like intense. It's intimidating, but it's deep listening. So,
I thought I was being caring, but I really have to work on that, because when I'm really paying attention, I can.
So softening our face, nodding, and making sure the smiles are at an appropriate time. Because our smiles can mean that what happened to them is okay, or we think it's funny or something. So again, and that can be part of your rules and guidelines, that if you see or hear me say something, or a look on my face you're not sure about, ask me. And I want to make sure that we're connecting and we're understanding one another, and I will do the same with you. So, all right. Supervisory issues. So really, the other piece, based on what you guys are saying, the supervisory relationship is confidential. the fact that they're in supervision with you may not be confidential because people see them coming and going and they know what their status is as an LPCA or LCSW or CSAC or whatever. But what happens in that session is absolutely confidential. Your notes are also confidential. So keep that in mind that when somebody says, oh, so-and-so said hi, that you supervise her, I'm nodding and smiling. That's it. You know, not going into anything else in depth or whatever. So remember, and when that supervisee comes to you with something, kind of like that situation where they had the clients telling her, that would be a breach of confidentiality unless she consented to that. So remember, they're just like a client to you as a supervisor. It's important to remember. So supervisory ethics, dual relationships. So what happens when you drive up in the driveway again and someone's painting your house that is in your SAIOP? What do? What rule applies?
The owner of the company and say, I've changed my mind. I'm not going to paint it this year.
Yeah. They're already painting the house, though, and the guy's on the ladder, and he says, hey, Charlotte, see you Thursday night. Who's the holder of the confidentiality? Who's the privilege of confidentiality? He is. Did he just break anything? Did he just create a problem? No. How you respond is either unethical or ethical. So you might just throw your hand up. If you're comfortable, you walk over and just say, hi, if you could come down for a moment, I just wanted to touch base with you. You come off to the side and say, you waved at me, and so the people here know that we now know each other. I just want to let you know that our relationship is confidential and that I won't share what our relationship is, and that's up to you, whether you share that or not. It's a little kind of unethical for you to be painting my house, and at the same time, you guys look like you're making good progress. And so if you're okay and comfortable painting my house, I'm okay. Now, if he's antisocial as I'll get out, and I'm afraid that, I'm just really totally uncomfortable with it, I might just cast up a hand and go inside and call the company and say, I have a dual issue with someone that's painting the house and would like for him to be assigned somewhere else. And that's even tedious.
When this happened to me, I was working the prison, and the worker who came to lay down brick, which would have been like a 2-week project, was a former inmate I worked with. So it was a matter of not wanting to get him fired, certainly.
Right.
But not wanting him on my personal space either.
Yeah.
So just calling the company and saying, I've really reconsidered what we're going to do. I appreciate what he's done. I'll pay for what has been done.
Yeah. So another option. Yeah, other options for dealing with it. All right, other dual relationships. Any others that you've struggled with? I didn't see any in here. Does anybody have one they want to bring to bear? Yes.
I had one where a friend of mine had married somebody that I knew might receive services from my residential program. There was the potential that that person was going to come into residential. And I had avoided being at her house, being a part of their relationship, and trying to figure out what to do about residential treatment and a friend of mine's spouse.
Yeah. So you just have to hold those boundaries to what you're comfortable. Well, what did you end up doing? What was your decision on that?
It ended up not actually happening, that they didn't end up coming to the treatment, but I was pushing hard to be reassigned to a different area for that period of time, and was getting a lot of pushback that was not something that I needed to work on my boundaries.
Yeah. Well, we ran into that quite often.
I think that's what I'm doing.
I'm doing that. I ran into that quite often at ADAC because we serve all of Western North Carolina, and I lived and worked in Black Mountain, and if somebody wanted to get sober in Black Mountain and go to ADAC, we all going to know them. It's a small town. And once in a while, what would happen, they would give them the option of going to the Butner, the ADAC down there, or staying here. And sometimes they didn't give them the option, but again, the holder of the privilege is the client, except when the client makes a poor decision. Like, yes?
So this is a specific issue that came up for me. Working at the VA, I also served in the Army National Guard, and so someone I served with, it was their sergeant. Is now coming to the VA, and it's the only game in town for that.
That's it.
So
there are a lot of choices.
A possibility of that issue coming up. Of like, sometimes I'm going to be covering a group that this person may be in, and how do we handle that? So that's just one where it's a lot of gray. Trying to navigate those boundaries.
We're going to run into dual relationships, and reducing that and holding boundaries to the best of our ability and checking that out with the client is really important, because the more you get into rural environments and small areas, you're going to run into it more and more and more. Yes, ma'am, Katie?
About 7 or 8 years ago, I did DWI groups, and I had a client in my group. She had like 30 or 48 hours to do. This was like in the spring. And then in the fall, my son was starting kindergarten, and I realized he was going to be in our kindergarten class.
Holy cow.
At least it wasn't the bus driver.
I didn't know what to do. So I called her, because I still have her number, and I said, how do you feel about this? I said, I'm okay with it if you are, but if it makes you uncomfortable, I'll call the person and switch in.
Everything worked out and was fine. That's when you know you're in a small town. And when you're saying that, I grew up with the 4th grade teacher. Everybody knew she was an alcoholic. She never got any DWIs, but that was the talk. And I went to church with her. It was. Then there's the jeweler who rides the lawnmower down the side of the street, because he's had like way too many DWIs, and even he was in my SAIOP.
Steve.
What?
DWI Steve, he's on YouTube too. As well, along with Resting Bitch Face. So they're great.
Oh, watch that. Okay. All right. Oh yeah, sure.
Opposite hers, because I used to be a school teacher.
And
so I've had former students come that were going to be in my group. And so I just kind of And so I can always just pull them aside and say, "Are you okay with this?" And if they're not, then I pass them on, and if they are, then
keep them. It can actually be pretty powerful. To be with someone. I've walked in in the emergency room, and someone that I had known when I worked at ADAC who had relapsed was there, and I said, if you would like me to get some else. He said, no, I want you. I know that you'll maintain my confidentiality, and I really need someone who gets it and knows me. And I did. I stayed, and it was a positive thing. So. Really, again, remembering who's the holder of the privilege, having boundaries, looking at the gray areas, do no harm, and do the best you can. Because in the gray areas, there aren't any hard and fast rules. Let me get Don. He's had his hand up and he's losing circulation there.
Probably helping you. Dual relationship, I wrote one in there, and it was interesting that the practice board, when I reported it, didn't feel that it was a dual relationship. And the scenario goes like this, and you've heard it from me before, is that a couple individuals decide that they're going to go to online university and they're going to open up a substance use facility. So while they're going to school, they find out that they have to have supervision to become interns, registrants, interns, and then
all that,
associates and all of that. So they hire themselves a CCSI, CCS, it was a CCSI in this particular case, to work for them so they can open up their facility, and that person can provide services in the facility they now own, and also provide supervision for them in their credentialing to move towards licensure. So the supervisor is not only an employee of the organization, but is also supervising the owners that signed their paycheck. I saw it clearly as a dual relationship.
It is.
The practice board did not.
And I mean,
they got licensed.
They did. Everything just flowed.
That supervisor lost their job the next day. I mean, so obviously that was and it's justified to me. So.
And that's again that gray area. So it's, and when you look at agencies that have CCSs in-house that supervise their people, those CCSs are also the administrative supervisor and have the ability to hire and fire. And that's unethical, but it's been going on for a long, long time. And that really places the supervisor in the most jeopardy because, though we're a no-cause fire state, if you reveal something that you have concerns about to that supervisor and they use that to fire you and don't clearly delineate between their clinical hat and their administrative hat, boy, now you've got a really good lawsuit there. So be sure if you're carrying the function of both clinical and administrative that when you sit down with someone and you're supervising them and you offer both or you have to provide both, that you say, I'm telling you right now, I am now your clinical supervisor and what you share with me is confidential unless you harm yourself or someone else or a client or whatever, And now I'm sitting down with my administrative hat on. I noticed you come in about 20 minutes late each day. What's happening and how can I support you to be on time? And then if they don't follow through, and that's well documented, then releasal. Kind of following me? So really being careful. And the LPC board, who I've talked with more than once about this, said that when in my disclosure statement for LPCS, I have that where it says, when I was at October Road, I had it, I don't now, but I will provide both administrative and clinical, and I will tell you which role I'm in when I am sitting down with you. And I was very careful to do that. So you just have under your disclosure statement, clinical, administrative, and your functions in each. So it can be very helpful. All right, moving forward. It feels like it's lunchtime because we started so early, but we'll 40 minutes and we'll be heading out to lunch. Let's see, confidentiality, we covered that. Monitoring performance, ethical and legal violations, disclosure statement, we covered that. Entering into a contract with them. So remember that you are contracting with your state licensure board to provide supervision for that supervisee. So you're actually contracting with a licensure board. And keep that in mind because that is really important when you're thinking about following rules and guidelines. Because if there is an issue where you're being sued or something, they're going to pull your documentation, they're going to look at your contract with the board, and did you follow that contract? Having emergency backup is important. I don't have an emergency backup. Because I'm not at an agency, but at an agency, it's really important for them to, if they can't reach you, they have another person that they can contact. They have my cell phone number, they have my home line number, because living here in the mountains, cell phones don't always work. But I'm usually within reach, within an hour or so. And I do check my phones pretty often, even on the weekend. You don't have to have physician backup unless you're in an agency or with Medicaid. Gatekeeping just means that there is no ethics or legal police for our professions. We're the gatekeeper. When we see something that's egregious, we need to address it with that supervisee. We need to address it and or with the client, and then report that as necessary, or look at a plan of correction and connecting with HR around that.
Could you share some examples of how you used gatekeeping where you did need to stop someone in their process?
Gatekeeping, I didn't need to stop them in their process.
Where it was,
yeah, give me a second because my brain went right to where I had to stop them in their process.
Yeah, no.
Yes, okay. So I noticed a supervisee who we were doing groups together had real slow behaviors, began to have a little bit of slurred speech. I knew that she had taken migraine medications, and so talked with her about that. She told me that she was taking a benzodiazepine because it reduced her anxiety that was triggering her migraines. Didn't feel the need to stop that. I said, this is what I'm noticing. And I said, it can be triggering to clients. You may want to look at reducing your meds or talking with your doc about that, but you wouldn't be able to come into SAIOP with slow movements and the slurred speech. And it wasn't severe. The average person probably wouldn't even notice it. But knowing her history, and as I did, of her mental illness and substance abuse. So anyway, she wasn't able to stop that. So I referred that to HR, and HR handled it with a urine screen. They did levels, I think. And it was the combination of the two meds. And so they titrated her down on something. And she was a great counselor, but she couldn't see it or hear it, you know, and sometimes we can't. So we just had to be the gatekeeper, but keep an eye on it and keep it moving. And of course, in my head, I'm like, she's abusing the benzos. I mean, you know, because I'm a substance abuse counselor. She's abusing the benzos. She's abusing it, you know. I had that in my head. I just kept having to tamp that down and back. Yeah. Thanks. Good question. And burnout. Well, we see that, don't we? Time to take a vacation. People that save up their vacation and won't take it and are burned out, that's an HR issue. You don't get to save up your vacation and be burned out and stay employed, because that's what it's for. So it's really important to keep that in mind, that HR can be your best friend. So again, confidentiality, what's said here stays here, and we do carry vicarious liability. I still do this. On some of the supervisees that I work with, they want to call me about everything. Y'all know that supervisee? Yeah, they're nervous Nelly about everything. I worked with a client this week, and he was suicidal, and I had a safety plan, and his wife even came and got him, and I did all these things, but I am so worried he's going to kill himself. And then, you know, I go into how much control do you have? You can't stop them, you can't make them, you know. So we go into just talking a little bit about suicidality and how we don't control clients. We bring them to the table and we work the best we can. You did the safety plan. You even had his wife come get him. You talked with her. She's aware of his current state. If he's able to keep himself safe, he gets to go home. If not, then making sure he gets to the emergency room. Then I got a call in the same afternoon. I've got a guy who's not answering his phone. He said this week he was drinking, he was suicidal. He's now not answering. And I said, is there anything since that time that you're concerned about? No, I just want him to answer the phone. No, you don't get to do that. You don't get to harass him because he felt suicidal when he was drinking. And she said, but what if he's dead? And I said, somebody will find him. And there's nothing you did to cause it, and there's nothing you can do to stop it. There are things you can do to help him stay safe, but cause and stop are not on board.
Police will do a safety check, a welfare and safety check.
Right, but you better darn well have a reason for a safety check, not just because he talked about suicide this week and he's not answering the phone on Saturday because he's probably outside mowing the yard. You know? Now, if he just called and said, I can't go on living like this, click, by God, I'm calling 911 really quick. So, you know, that's having a reason. Remember, LPCS, LCSW, CSACs, LCAS, this is all new territory, and it's frightening. I'm not sure I want to be a counselor anymore. I'm overwhelmed. My husband's telling me that my work is killing me. I mean, you could see it all come together where this woman was really in trouble, really struggling. And I could have walked away from that, but she was looking at me with that imploring, please help me. And so just stopping and taking those few moments to interject felt appropriate. And again, had it have been under active supervision, I would have just made the therapy referral. I wouldn't have asked that open-ended question. And two, I go back to, I just got a phone call. Someone's wanting me to do therapy with the wife of one of our EMS workers that committed suicide back last year. And I don't know the EMS person, but again, that's, boy, do I want to start getting involved with the company that I work for and helping people who have trauma. So maybe you're still employed there too. Yeah, a lot of the trauma therapists work for the same company. Because we all do trauma work. So, all right, so structure your own ideal clinical supervision, whether you're going to do group or individual, the theoretical model, and I can't encourage you enough to look at the theoretical models that are in here. Powell's blended model is the one they ask the most questions about. So Powell's blended model, you definitely want to know that one. And the last one that he created is the contemplative model. And so, you know, CBT flows into supervision. Cognitive behavioral is actually a model. Developmental is actually a model, theoretical model in supervision. How would you begin and end? So again, beginning that session with something to calm and ground the supervisee, and ending it with maybe what did I say and do that was helpful in our supervision so that I can do more of that. What did I say and do that was not helpful? What kind of change will you invite from that person? Really inspiring them again. What kind of skills do you want to get? What kind of work do you want to do? And you know, in the old days we'd say, boy, everybody's got to get substance abuse training, right? Because you're going to run into substance abuse constantly. It's out there. Now what are we saying? You've got to get trained in trauma. Because 99.9% of people we're going to see have trauma or adverse childhood experiences. And we've got to be trauma-informed ourselves. And that means chronic stress-informed as well. When we're under chronic stress, we're traumatized and our fuse is short and we're judgmental and we get burnout and compassion fatigue and we're not real helpful at that point. So pretzel up, plenty. Yes?
Is this information still out of the Tip 52?
Yes. Yeah, everything I'm sharing with you today is from Tip 52. What kind of change will you invite? What content or instruction is important? Really, like anytime you go to a training, go back and teach your supervisees. Give them some handouts. Empower them. And all the supervisees I've ever worked with, I recommend highly motivational interviewing and counseling. It is a beautiful model that for the first time for many of these supervisees, it allows them to keep the responsibility of change on the client and not them. Because they come through school and they think they're going to fix the world. They're going to save the world, right? You know that? Yeah, so it's really important. Motivational interviewing keeps the locus of control with that client. Nothing does it better than that. And then how will you evaluate yourself? All right, just a review of basic skills in clinical supervision. The case presentation, starting off with, again, strengths and not problems. Strengths, what works well, then move to problems and solutions, what's worked so far. Then go to demographics, name, age, marital status, occupation, education. And, you know, and when they say, oh, he doesn't have any education, or he was a high school dropout, are y'all going to let that lie? No, because he may have a trade, he may have skills he learned from his dad, he may have learned carpentry from an uncle. We need to really delve into what work have you done in the past, what do you love to do or not love to do, and what are your skills? What do you do? Do you help out around the house? What do you do? You know, just really working with them. Identify strengths and history of treatment, whether it's mental illness treatment or substance abuse. Identify the problem statement, why the client's in treatment and what their diagnosis is. What are their treatment goals? The one thing that I go back to every single week that I do supervision, they'll tell me about a client and they'll be staffing, and I'll be wondering, what are the treatment goals? Because I'm not getting them. I'm not hearing where they're going with this client, what they're supporting this client to do. And if I look at them and I'll say, what are your treatment goals? They'll go, it's like they've forgotten the goals themselves. And when you ask that, then that can tailor that conversation around, well, our treatment goal is to get her back into school, even though she's 16 and she has 2 siblings, and I'm doing intensive in-home, and I get there and the mom's not drunk, but there's new beer cans everywhere. And so what are your treatment goals? Because if not, my brain just went blah, blah, blah. because they're just giving me all these scenarios to get the girl back into school, to support the other two children, younger children, to get into therapy. They have trauma. And I said, what about the mom you mentioned with the beer cans? Well, I haven't really included that in the goal. And I said, well, you know, if she's got a lot of beer cans and she's not able to make her rent by Friday, I said, is that changed? She says, no. And I said, so if mom is drinking and they're not going to be able to pay their rent, what needs to happen there? And then that's a DSS report. Or you can enable the mom and go down to Eblin and get the rent money or something like that, which you still may need to do, but I would talk with your supervisor around that and see if it's reportable, if it's a reportable case. For those of you that are in the Buncombe County area, Mick McGuire, in fact, he travels over a wide area, but he presents on adult and child protective services. So if you need a presenter at your agency to talk about North Carolina law and a good screening tool for APS or CPS, he's excellent. So, Nick McGuire. Let's see, problem statement, where are barriers to treatment? This is probably one of the most important questions. What's getting in the way of the client succeeding? What's getting in the way of you being able to help that client? And so looking at those barriers and knocking those down. Any counter-transference. So this may be the first time that you teach transference and counter-transference with a supervisee. Now then, my question is, can the transference begin with the counselor, the supervisee? Have transference towards the counselor, and the counselor then responds with countertransference. No. We know when our buttons are pushed. We know when that person walks in, well, then nobody going to be able to help him. He's resistant, he's dirty, he's homeless, he's drunk, he's angry, right? We know those clients. And it's Friday and it's 3 o'clock. Yeah, and he's 30 minutes late for his intake. So again, that's transference. And recognizing, one, that he's homeless, two, that he is biochemically addicted, three, is all he could do to get there because his tent got shredded by the police last night and it was really cold and they took his sleeping bag too and he wandered around in the woods until he finally, the shelter opened up. You kind of see where I'm going? We don't know his story until we listen. So be aware that transference, countertransference goes both ways. Plan of action based on case presentation. So this is at the, whoops, that should be an 8. I'll pretend like that's an 8. Plan of action based on this case presentation to improve treatment delivery and client outcome. So based on this case presentation that you've just done with the supervisee, what is the plan of action? What will that counselor do differently? What new resources are now available to assist? So it really just puts the structure into chaos, because when they're bringing that case presentation, chances are they don't know what to do, they're stumped, they may have transference, they may have countertransference, and this just gives a format to really spell it all out. Sound good? Mm-hmm. All right. Psychoed, teaching them something. We talked about that earlier. So what have y'all taught in the past to supervisee that you really saw a big change in their behavior or performance? What have you shared that's really made an impact? Gloria?
Yeah, I have an intern, and she was very concerned and putting herself in a bad light, because she was taking everything personally.
Okay.
And I said, "Are you taking everything personally?" And I said, you're dealing with sick people.
And yeah, coming out of a disease process.
They manipulate and they connive and they do all sorts of things, okay? And you're going to take all that personally? What you're doing, and I know what she was doing, it was perfectly on target.
Yeah, we all have reactions. We just have to get in touch with those.
So she was grateful for me telling her that.
Yeah.
Yeah, I had to go back to my early days.
Yeah.
Where everything was personal. Everything was personal.
Yeah.
And it's not.
Yeah. So how do we not take it personally? What does it look like when we don't take something personally?
It looks like mindfulness.
It looks like mindfulness, that we pull back and we get in touch with our own internal process. We take a few deep breaths. We may give ourselves some messages. This isn't about me, this is about Cindy. And Cindy's really struggling as she comes out of her disease process. In fact, many people, when they come into treatment, are still in their disease process. Right?
So we've talked a lot about, in the one that I do, being culturally informed, because we do work with Eastern Band community. And so we do a lot of conversation around being culturally informed and different treatment modalities in regard to, the medicine wheel and such as that. So a lot of conversation around being culturally informed in that environment.
Yeah, so being culturally informed in that environment with the Eastern Band of Cherokee, yeah. Yeah, and how they use the medicine wheel and various aspects. And again, not looking straight on, for us, eye contact, but for someone who has been culturally oppressed like that straight on eye contact can be very intimidating.
A lot of conversations around spirituality because, that's huge.
Yeah, spirituality is everything.
Culture, so a lot of conversation around that. What's appropriate, not appropriate, that kind of thing.
Yeah.
One of the first things it seems like I teach is just doing a simple sociogram of how a group's supposed to work.
So teaching a sociogram about how groups work.
Particularly new clients think they're totally responsible for the group, and it puts a lot of pressure on them. They can't even think of what they do know already. So I teach them how to back off from the group.
Yeah.
Let it work.
So you're talking about new supervisees are more responsible for the group and try to control it and make it work and worry if it's not, and teaching them how to facilitate a group rather than control or make the group happen.
But it's not
Yeah.
always new. It is new, but it's not always new.
And it doesn't hurt to revisit those 10 to 12 skills of how to draw out the quiet members, how to block, how to connect, how to facilitate group movement, and the stages of group, and how the group forms and storms and then goes into the action stage. And that will give them a lot of foresight into what's happening in the room and how not to get in the way. Anything else that you've taught that's been really helpful and changed behavior in supervisees that you've worked with? Yeah.
I work with a lot of interns who they're working with their first clients ever. And
yes.
At the very beginning, outlining that there's very little they can do in 1 hour that's going to really screw everything up.
Yeah.
That we can't come back and maybe fix.
Yeah.
And then I give a couple examples of things I've really screwed up and then how I've tried to come back and do that. And so that opens the door to, let's talk about like what didn't go well and how we can come back around to it at another session if needed. And so that kind of opens the door to, yeah, it's not all going to be perfect, but it'll be okay.
And we own our mistakes. When we make a mistake, we own that. So the other thing is, how do you deal with the supervisee that does a first urine screen and it's positive for cannabis, and that client is standing there saying there's no way, and then the supervisee comes to you and goes, I believe him, there's something wrong with our test, and then you see the succeeding behaviors of I know y'all chuckle, you see the succeeding behaviors of getting bought into and invested in the stories that the substance abuse client begins to sell them. So how do you deal with that? What do you do with that? And how do you do that without making them feel stupid, dumb, or bad, or wrong?
Or jaded.
Or jaded, yeah.
Well, I always go back to the story that Dottie Green told us when we were in graduate school.
This will be good.
The hardest part of our job is when we want recovery for our clients more than they want it for themselves.
Yes.
I know this is really hard, but, here's the evidence, here's the facts.
Yeah.
And just sharing my own stories because we've all been there and done that.
Yeah.
We've been, because I want so bad for them to reach their goals, to be able to get well, that I want to believe them.
Yeah.
And it is hard.
Yeah. Very good. So being able to work with that client and recognizing that sometimes we want recovery and treatment recovery for them more than the client does. And, you know, and we have a policy. There's a chain of command. After they urinate in that cup and they give you a urine sample and you've dipped it in that quick dip stick or whatever, and it's showing, or the cup now that has all the strips on the side that's all fancy and the temperature and all that stuff, and it shows positive, that's a screening. It then needs to go through a chain of custody, command custody up to a lab and be tested at a lab. And at October Road, what we used to do is, if you want to contest this and take it on up to the lab, it's going to be $49, and you can pay that today. It's amazing how quickly, well, I just smoked once, you know, or my girlfriend was smoking, or my kids smoke crack in the house, but I don't smoke. Yeah. Or she blew crack smoke in my face. You know, you've heard it all. What are some others? They're really good. I bumped into somebody in the elevator. Yeah.
My best one, the people that I rent an apartment, and the people that rented before me were cocaine dealers, and when I was dusting, I got some of the old cocaine in me.
There you go.
Secondhand cocaine.
Lucky person, secondhand, for free.
3 times over a 4-month period.
3 times. They're really doing some cleaning. Yeah. So yeah.
Licking the floor.
Yeah. Yeah. So what we end up seeing is that disease process is very powerful. And a lot of times supervisees don't know that disease process, and that most people don't get clean on their first try, and that it can take time to be able to get clean and stay clean. And to just say, you know, I want to be honest with you, you know, this is a screening and we can take this on up and have it further tested, and then quote whatever your company policy is around that. Yes?
I love this little story that I tell both clients and my interns. There's a little doggy in the back window of your car. It's got a bobblehead and just goes like this. And I said, if you do that with a client, or if the client believes that you're going to swallow everything they say, is anybody getting well? I said, somebody has to tell you the truth, and it's not always kind, it's not always pleasant, but somebody has to tell you the truth if you're going to get well.
Yeah. And that truth can change with each individual. What we want to do is explore that, see what their truth is, what are they struggling with, and to validate and support the client around that. All right, 10 minutes. This is the longest morning ever. When you start 30 minutes early, it really is a long one. So role-playing and modeling and demonstration, and as much as sometimes folks don't like that, role-playing is acting out a current struggle that a supervisee is having with a client. And you might say, show me what your supervisor's doing, your client's doing. Show me what your client is saying, so that they can give you real-time kind of comments and behaviors, so that you can truly understand how difficult it is for them. So role-playing can be used to also practice skills. Role-playing is learning by doing. A supervisee and supervisor may take one on the role of counselor or client. Roles of each must be specific to the counselor-client situation, and debrief afterwards to ascertain what was helpful, what was not. I'm always surprised, not always surprised, but I'm sometimes surprised when I'm teaching a skills-based training where they'll ask for a role play so they can see that skill being carried out. So we know that observing a skill is very powerful, as well as talking about and learning that skill. So role play can be very powerful transference of skills and skill base. What if I just said, here's how you do the pretzel, and we never did it? What if I told you about the pretzel and then we kind of demonstrated it, but we didn't hold it 2 minutes, so you couldn't feel what it was like? Do you kind of see where I'm going? It's going all the way down that rabbit hole with that skill, practicing what does it feel like. Recently, Mission Hospital has this great program where we get a reduction in our premium if we do certain things to, we take a health inventory. If you're diabetic, you can set up appointments and get your blood sugar checked and see a nutritionist and all this stuff. One of the things is that you get 2 free appointments through EAN. And I love doing that. It's free therapy, and I don't get free therapy very often. So anyway, to be able to go back in and sit down and be the client is very powerful. And ironically, the person that is the counselor is an ex-supervisee of mine. But it's been so long, when he saw me, he was like, "Ooh!" And I went, "But I know everybody here." I can't, and I said, when they said Laura and Colin, they said, "No, I work with her. No, I'm teaching with her next week." And all these people. And then they said, "Rob." Well, I only know one Rob. And I thought, surely it's not that Rob. I said, what's his last name? And I'll keep the confidence. And they said his last name. I went, "Oh, crap. Oh, no, that'll work just fine." Because I remembered it had been quite a while. But at least I know his expertise, and I trained him, and he's had other training since then, and is an excellent therapist in internal family systems. So if you need an IFS referral, I got the guy. He's really good. 20 minutes into the session, I'm slinging snot, crying, just letting it rip. And then I got quiet and dropped into a deep state of hypnosis and did incredibly powerful work. So I got to not only do IFS, I got to do the model that I'm doing, teaching right now. So again, going back into therapy is very empowering and very helpful. It reminded me, as my hand touched that doorknob, what a client who became a CSAC once said: "We've got to remember the courage that it takes for a client just to turn that doorknob to go into therapy." You've got to remember that courage. So as I was turning that doorknob at EAN, I thought, I'm using courage, And to have a supervisee work with me, he was really panicked. I was like, "There's no judgment. I need help." And he said, "Okay, I can do this. So it'd be like Jolene. A few years, you can work on me too. Right.
That's too much.
We share an office. It wouldn't be ethical. But you're a good counselor, and you're learning incredible trauma techniques. That's the thing about being a trainer. We know who does a good job because they show up and they practice hard and they're really diligent about learning those skills. Role modeling, and we're done for the morning. Role modeling is learning by watching someone else. We already did most of that, so let's skip that. Demonstration, that feedback and intervention. Remember the sandwich rule. And covering the other pieces, deconstruction means to break it down, and I think that's on your CCS exam as one of those techniques, to really deconstruct what the supervisee is telling you. Because they'll just launch and go, and then he said this and that, and they'll just start talking. So let's go back to the beginning. When that client walked in, tell me, when that client walked in, tell me what he or she started with and what they said. Let's say they've lodged a complaint against them, that they didn't help them, and in fact they were even rude to them or something like that. Boy, when you get one of those calls, it's like, how do I deal with that? I've got to deconstruct what happened. So when that supervisee comes in, let's just start from the beginning and take it nice and slow, and you share with me. And you'll hear from them when that relationship started to go south, if you're really listening. And then help them look at what they might have done differently. I think one of those that I had years ago, the guy came in and he said, well, the counselor said to the client, and it turned into a big HR issue. He said to the client, if you can't come to SAIOP on a Monday, Wednesday, or Friday, we can't help you. Now, what's wrong with that? There is no wrong door. And even if he couldn't come on a Monday, Wednesday, or Friday, what's our obligation? referral out. But that guy left, and he called back the next morning and lodged that complaint. And that was good, because that was what the person was saying up front before he even did the assessment. If you can't, well, how can you know somebody's going to go to SAOP? And I asked him that. I said, how is it that you were thinking that everybody needed to go SAOP? He said, well, that's all we offer. And I said, no, that's not all we offer. That's all you teach. There's other levels, and then talked about aftercare as well as the 20-hour, 40, 60, and 90. So he didn't somehow get that piece, because he typically came in the afternoon, worked at night, did afternoon assessments, SAOP at night. He didn't even know we had those 20, 40, and 60-hour groups going on during the daytime. You kind of see that wasn't a mean thing, it was just a limited knowledge thing. But had that client not called back and lodged that complaint, we wouldn't have known that. Which horrifies me when I think how many people got turned away because of the lack of knowledge. And they probably felt like they don't want me, that rejection kind of thing. So supervisor always supports the counselor to self-observe, self-correct, self-reinforce, and self-soothe. And self-soothe is right up front, doing that pretzel. All right, so we will meet back here as close to 1 o'clock as possible. All right, so I want to cover a few slides around guiding principles of clinical supervision. Clinical supervision is a right, regardless of your experience level. And why is that? Why is it a right to get clinical supervision? The law says it is. Ethics says it is. Liability says it is. They come in and they say there's no regular clinical supervision, your agency and you are much more liable. So again, it's a right, because we have a right to have someone to help us work through problems or issues that might come up in our practice. Clinical supervision needs the full support of agency administrators. And in that tip 52, there's a wonderful model in there for determining if your agency is ready to open up to clinical supervision and how to work with an agency to get clinical supervision in there. Now, it's a given if somebody's in licensure, but this is supervision beyond licensure is really important.
What's considered regular?
The gold standard is 1 hour per 40.
For every level?
For every level, yeah. Now, with NCSA PPB, the 300-hour practicum is 1 per 10. 1 per 10. Oh, that's intense. Unless you work at the agency, it's going to be really hard to do that. But it's still there. Guiding principles is the supervisory relationship is the crucible in which ethical practice is developed and reinforced. So again, the ethical practice is important. They're able to bring things to you, you're able to see things and bring it to the attention of the supervisee. Clinical supervision is a skill in and of itself that has to be developed or you'll parent. That's what David Powell said. So it's an authoritarian relationship, it's a power differential, and the only time we really experience that as human beings, as children, when we're growing up. So that becomes your model of how to work within the power relationship unless you get training in good, strong, evidence-based clinical supervision. Clinical supervision and substance abuse treatment most often requires balancing, again, that administrative and clinical. Can you do both? Yes, you can do both, but you really need clear guidelines around that to do no harm to that supervisee. Culture and other contextual variables influence the supervision process again. And some of those contextual areas are talking about the developmental, where the counselor is developmentally, where the supervisor is developmentally, and working within those parameters. There's the gatekeeper. Isn't she gorgeous? She is one scary woman. Successful implementation of evidence-based practice requires ongoing clinical supervision to identify and incorporate them. So really looking at what that individual's doing. If somebody says, oh, I'm doing art therapy every Thursday, is that in their scope of practice? Are they doing that in an SAIOP, which is being billed to an insurance company or Medicaid, and that's not accepted as evidence-based? So you have to be really aware and careful what you're using that's evidence-based or not. Supervisors have the responsibility to be gatekeepers for the profession, and we've already talked a little bit about that, and Marie had a great question around that earlier. What's an example of it, what we covered? Clinical supervision should and must involve direct observation methods when at all possible. Don't you love Freud there? And working with resistant staff, to quote Wolverine, I'm the best there is at what I do. So I don't need your suggestions or your supervision. Everybody had one of those before? If you haven't, I highly recommend them. They'll cause you many sleepless nights and much frustration. But what they're trying to say is, I'm self-assured. And they'll be self-assured until they have a very difficult client, and then they'll be knocking your door down wanting help. So I'm just coming to supervision because it's required. How many times have you heard that? Yes. And say, yes, it is required. Have a seat. And there's a case presentation format there if you'd like to bring a case to bear that you're struggling with or that you're very proud of. And you just roll with the resistance. It's MI as a supervisor. Now, wait a minute. Did she say what's the difference between supervision and therapy? And I'm using MI? The gray area. But MI doesn't have to be therapy. It can be coaching. It can be supportive. Strategies for working with those individuals, you want to level the playing field, meet in their office, do some walking supervision, keep structure in it. In other words, that case presentation. Ask them, how may I support you? Really validate, support, catch them doing well, disclose as appropriate, and we'll skip that group exercise, but getting them into group supervision can be very helpful. Takes the fight out of them. Getting started as a new clinical supervisor, learning policies and procedures, and taking the time to work within the organization, knowing what you're supposed to be carrying out, such as drug or alcohol policy that we brought up earlier. So they say it takes 3 months on the average to really learn your role as a supervisor and the policies. Take time to learn about the supervisees, their goals, their strengths, their aspirations, and always remember their dog and cat's names, much less their children. It'll get you a lot of mileage, right? Because it says you care. Yeah, know what they love and support them to use that or do that. Work to establish a contractual relationship with clear methods and goals. And if you use the IDP, the individual development plan, that'll help with that. Learn methods to help staff reduce stress, address competing priorities. What happens when they say, okay, I'm supposed to do 3 SAIOPs a week, 6 assessments a day, and all my notes, and I can't do that? Then empower them and advocate for them to talk with their administrative supervisor about that. Crunch the numbers. Help them actually crunch those numbers. If you work an 8-hour day, you're doing 3 SAIOPs, doing that many assessments, plus the paperwork, really help them have tangible math to go to their supervisor and see if that's helpful. Find a mentor, shadow the previous supervisor, get feedback from your supervisees. Have weekly meetings with your direct administrator to understand what's working and what's not at your agency. Seek supervision of your supervision. There's a group of supervisors that meets up Merriman Avenue one evening a week. When Levi was alive, he met with them a few times and would always report back about that group. I don't know if they're still meeting. Does anybody know if the supervisors group is still meeting? Seems like it was a Wednesday or Thursday night.
There's a few little consultation groups that meet.
Okay, so those can be very helpful. All right, well, I like this statement about what the new supervisor should know, do, or portray. David Powell would say, be human and have a sense of humor. We all make mistakes. Success requires them. Success requires mistakes. Rely first on direct observation of the counselor. Request their feedback before offering yours. Supervision is, who said this? Supervision is all about the relationship. Counseling is all about the relationship. Carl Rogers. So cultivate a relationship. Going back and picking up, make time to care for yourself mentally, physically, and spiritually. I find myself, if you do supervision back to back, I do one whole day of supervision. How's your back feel about 3 o'clock? Sore. And kind of you start getting antsy and you need to move around. So I used to just see people right through. It'd take like 30 minutes for lunch. I don't do that anymore. I take a full hour for lunch. I go walk. If somebody cancels, I'm on that sofa taking a power nap. You know, you got to start taking care of yourself because you're listening all day long, directing, supporting, take time off, get out. And thinking, yes, thinking. Let's see, yes?
How come they don't have to require LCAS to have supervision?
After they get their LCAS, say they get their full LCAS, that's true of LPC and LCSW as well. After you get your licensure, it is up to your agency and yourself to make a decision about your supervision. Now the gold standard is 1 per 40, and agencies should provide that, and it reduces the liability of if you're being sued to show that there is clinical supervision and clinical oversight. It's kind of like our government running with no oversight. But we do it in agencies. And that is what's happening. All right, and supervisor, again, developmental stages. We went over this last time, but I'll just breeze through it. Level 1 is that anxious regarding their role, a little bit naive about assuming the role. They're very focused on doing the right thing and just putting a lot of structure and support in with that counselor, encouraging them. Catch them doing right is the thing to remember there. Level 2, they show confusion. This is a stage where they're like an adolescent. The system is wrong and bad, it's broken, you know that stage. They don't really care about helping the clients, they're just all about the money. Well, that's true in some cases, but not all. So really helping them look at where they can make a difference, where steady and slow wins the race, looking at helping them balance work and play, helping them recognize what the disease process is and sometimes how clients can deny and minimize and how they can get drawn into that and if that's helpful or not. So really spending a little more time with them and supporting them. The level 3 counselor is highly motivated. They provide honest self-appraisal. They're comfortable with an evaluation process. They provide thorough objective feedback and offer the supervisee to self-evaluate, elicit feedback. Level 3, did that just skip? No. All right. So how often do you do evaluations?
Every 6 months.
Every 6 months. Most agencies, it's right at a year. And some other agencies, evidence base is quarterly. So again, at least annually, and if not annually, if you can do 6 months, that's even better. Formal versus informal. You can do informal evaluations almost weekly. If you have a supervisee or a counselor who's struggling, then you would want to meet with them, develop a plan of correction, and then look at them weekly. And that's on the administrative side. On the clinical supervision side, again, that's still corrective and looking at it weekly. All right, let's take a few minutes to staff a few difficult supervisees with the rest of our time if we're going to finish early. So difficult supervisee, what's the most difficult one you've ever had? Most difficult supervisee you've ever had?
Really challenging supervisee. I was sharing with this group, she and several other people I was supervising did in-home. They were right out of school.
Mm-hmm. In-home intensive in-home.
I'm sorry, kiddos in school.
Yeah. Oh, kids in school,
They
okay.
had no tools.
Okay.
They had built, and they were smart people.
Right.
But, you can't, it's difficult to create change when you don't have access to the children's parents or the children's.
Right, so they're in the school working with children,
Yeah.
straight out of school themselves.
Yeah. So already it was challenging for me as my whole professional career been around adults. So I staffed it with my supervisor, and she said, a supervisor is a supervisor, you're a good supervisor. But it turned out that I gave pretty much all that I had, and they needed tools that didn't exist.
Well, they were practicing out of their scope.
We were all practicing out of our scope.
Exactly, and that's what makes me crazy, and why I have released and referred out a couple of folks who are coming straight out of school, have not had any training in working with children, and they get hired in schools or in intensive in-home. It's extremely disturbing.
But I mean, it was more of a systematic problem because, in order to affect long-term change,
Right.
you really need to look at family systems.
Right.
Because so many of the families couldn't or wouldn't. I mean, we're talking Havelock, or what's the guy's name? I'm so full of snot and grossness.
Having that allergy attack. Yeah.
You can't do it.
Yeah.
So anyway, one of those supervisees, I mean, we all became frustrated with the process, and it was really clear.
Yeah.
And so I eventually did, slow motion transfer all of those folks to hopefully somebody that could deal with it better. But there was one really challenging supervisee who was so frustrated in general, and she took a lot of it out. She did a lot of name calling.
Yeah.
She was a bitch. She was an absolute bitch. And,
Which is trauma.
And I still want to hit her with a hammer.
Yeah. Sounds like some group karma there.
Obviously, I'm not going to hit anyone with anything.
Yeah.
But she was so rude to me, and it was everything I could do to call her out. And so the time came to sign off to recommend. Do I recommend this person for
So you didn't refer her out? You saw her through to the end?
No. That whole all.
Oh, okay.
She was in there. It was 4 or 5 people. I mean, it was
okay.
It was the whole process was quite painful. But the woman that was so incredibly rude to me. I mean, I'm a person. I did not take it personally, but I am a person, and she was talking to me.
Mm-hmm.
So it was pretty personal. So it was really difficult not to engage in a power struggle with her.
Because she was inviting that.
She was name calling.
Yeah.
She was abusive. She was blatantly saying, "I'm not going to do what you want me to do."
And so when it came time to recommend her,
I recommended her because I could not concretely, egregiously, say that she's egregiously done anything wrong just because she was, unprofessional to me. It doesn't mean that she wouldn't be a good social worker. So I didn't report a concern because she was rude to me personally. Had I been in a longer relationship with her, it might have been a different story. But that was my most challenging ever.
Mm-hmm.
Other than that, I've had fantastic experiences.
Good.
But I think it's so interesting that she literally lives 2 doors down from me.
Mm-hmm.
And that's a new development.
Mm-hmm. So anything you would have done differently looking back at that, or you feel completely content with that?
I feel like I might have done the same.
Okay.
I didn't personalize it with her. I didn't engage in a power struggle. I didn't report anything fictitious to the board because I didn't know.
Mm-hmm.
I didn't express a concern because maybe that's her resting bitch face. Maybe that's what her face looks like. I don't know. Maybe that's how she is to everyone. I mean, it's not against the professional law to be rude. I don't know if she treated her parents the same way. I just didn't have any personal privilege. Plus, I couldn't get in the school, so I couldn't see actually what was going on, which made me draw the line that I would never supervise someone that I can't get in and do direct observation with.
Yeah.
So that was a really helpful process for me in that I was able to create that rule for myself.
Yeah.
It was just a huge challenge.
Mm-hmm.
The process was challenging because of the system, and then the personality made it just wicked challenging.
Yeah. So you did or didn't refer her out? I didn't.
Yeah, oh yeah.
You did. So you didn't have her the whole time. You had her for a period of time and then referred her out.
No,
Okay.
absolutely.
Yeah. Okay. So that's the option, to let them know that, you know, this is, that you'd like to continue supervision, these would be the changes that needed to happen, and if they didn't, then refer them on. Yes?
So when you say refer them on, are you talking like as with our client, you set them up with someone, you confirm that they're separate?
No, with supervision, you don't have to, when you refer them on, is to say that in 2 weeks we'll be terminating our supervision for the following reasons. Is that enough time for you to secure supervision? And we don't have to make sure that they secure supervision. We just have to give them a timetable and then end it. Now, if they were to say, I need to continue my supervision for 3 weeks or 4 weeks until I find a supervisor, or I found one, but it's going to take the board 2 weeks to respond or something, then we, liability-wise, we wouldn't want to terminate it before they say that they've got somebody. But if they just don't, and if they're dragging their feet, then I'm sorry, I won't be able to continue past this point and then document. Yeah.
Yeah, I did that. I think like a 45-day notice or something.
Yeah.
And they figured it out.
Based on what she just said, I changed my policy also because I had a couple of supervisees who just, in my mind, made up BS reasons why I couldn't come into the agency to observe them directly. And it just sent up all kinds of red flags and or wouldn't give me permission to talk to their supervisor. I always get permission up front to talk to their supervisor in case anything comes up. And, you know, even if they gave me permission to talk to their supervisor, one of them, the supervisor said, it's fine if you come in.
Okay.
But yeah, guess what I found out? So I just don't, if they show resistance to that, I'm not going to be liable because somebody tells me what they're doing in group or with individuals. And that's just me, but there's plenty of supervisors, and although it doesn't require it, I believe that it's important.
Yeah.
And I'm not going to kind of feel my way around to make sure they're not doing anything unethical or harming the clients. And I always, in both cases, I had superstitions. Yeah, I had superstitions.
You had suspicion, yeah. Okay.
That they didn't know what they were doing in some cases.
Right.
I could have helped them, but
yeah,
they wouldn't let me in, and that was very shaky ground.
Especially it involves working with children. It's really concerning sometimes the lack of training where LPCs, LCSWs, A's are working with children without the appropriate training. I mean, like sand tray is rocket science for them. And even saying you can get online with PESI, you can order videos, you can start studying, you can start learning, and they don't. For some reason, they think they're supposed to do talk therapy with a 6-year-old or an 8-year-old or a 10-year-old, and that is not going to work. And when we, just teaching, and I wouldn't even have known to support them around this, but there was one little girl. We know that one of the first symptoms of sexual abuse is an upset stomach a lot in a child. Second is not being able to control urination. And this little girl was peeing into her shoes on a daily basis. And I said, first and foremost is to talk with the parents and get this child medically cleared. In other words, there's not a medical reason like an infection or even an infection that could be caused by sexual abuse. So really getting that child medically cleared. And she did attempt to do that, talked with the parents. They said she's been doing this forever and ever, and they're actually spanking her for it. And that they refused to take her to the doctor. And I said, that's a DSS report, so we turned that over to them. I don't know what the outcome was, but again, things like that is very disturbing because it's interfering with her ability to learn. It's symptomatic of sexual abuse. It's symptomatic of emotional problems. When they asked her why she wasn't going to the bathroom, she said she was afraid to go, which tells me that something's happened to her when she's gone to the bathroom before. So it doesn't seem like rocket science to me, but it's really frustrating for me as a supervisor to work with someone who has so little, if any, insight and knowledge about how to work with and care for children when it is such a critical developmental time in their lives. And so when I'm working with that individual and I'm not seeing any training or changes, I pass them off to someone else, and I make attempts to talk with their administrative supervisor as well, which usually ends in nothing because they're hiring LPCAs or LCSWAs because they get paid more when they bill Medicaid, because they're paying them to pay for their supervision, but they're not paying for their supervision and they're pocketing it and having the supervisee pay for their outside supervision. So it's, again, that's a very broken part of the system. But certainly when children are involved, it's very disturbing. So, in fact, I have yet to work with an LPCAA that is trained in child therapy that's currently working with children. So I'm not sure what that's about or why that's happening, but it's very concerning because it is out of scope of practice. I don't know about you, but if I'm working with a population I don't know anything about, I would be scrounging to learn all that I could so that I could be helpful and protective. Because it is to do harm when we're not trained to work with those individuals and we think we can do talk therapy and they don't respond to that. Even going outside to play and that kind of thing, doing play therapy is important. One of them, I actually bought a Nerf basketball to put on her door so the kids could shoot while they talked. Because you play with balls and kids will open up and talk. And art therapy as well. Other supervisees you've struggled with? Yes.
I guess I'll just mention one that I mentioned in our small group. It was standard practice that if somebody's personal issues are interfering with the work, that you would counsel them to seek therapy and suspend supervision while the therapy was going on. Mm-hmm. And that was back then, this was maybe late 90s. It was kind of standard practice. We talked about that, so it was. This particular individual was really tense and anxious and real eager to do everything right, but was to an extreme, and was doing kind of diversionary work with adolescent boys in a kind of a school diversion program, and would have multiple experiences of kids refusing to meet with her. I'm not sure just exactly why, but referred her out for treatment because of the anxiety, and she got really angry and refused to go to therapy, saw it as a punishment. So, it was just, I guess that's only happened to me twice with supervisees, and it neither time was it as elegant as it's always described. Go to therapy,
they get all better, they come back, yeah.
Now, and so that just didn't, it was, many years ago, it still sticks with me as a not a good outcome, and somebody that was so earnest to do well, but it was to a fault. Yeah. And it just, ended the relationship. I don't know where she went or what came of it, but it was not feeling like a good outcome.
Yeah. Well, thanks for sharing that. There was one ethical concern somebody had, like, I'm a type A. It's hard for me to know when to engage, when not to engage, when to give them suggestions, how to get suggestions or information from them. What do you do with that? We all have a little type A in us, right? Yeah. So how do you support that client to come up with their own solutions, to talk about what they do well, what they don't do well with, without pointing it out to them? What?
Motivation interviewing?
Yeah. Mm-hmm. What would that sound like? Use an MI with that.
Motivational interviewing.
Mm-hmm. What are some what would you be asking? What are some?
I love it.
I'm sorry?
I'm sorry.
That's okay.
I don't even know.
So with motivational interviewing, you might say, you know, on a scale of 1 to 10, how well do you feel like you did in that session? 0 being you didn't feel well at all, 10 that was the best session ever.
I find that more judgy. I mean, I think about motivational interviewing as facilitating people to kind of walk down the road a little bit or walk in a circle, whatever they prefer, and to get wherever they're going based on their own trajectory. And then when they get there, well, does this fit me? Does this where I want to
So
go?
what you would ask maybe what their goal was for that session and how did you get there?
How do you think things might be in 2 weeks from now, 2 months from now, a year from now, if things continue like they are? Like that's a motivational style question. Just asking people to ponder.
Are you asking the supervisor that or getting the supervisor to ask the client that?
Both.
Both,
Either.
okay.
Yeah.
All right.
I often ask supervisees, where do you see yourself in 2 years, 5 years, what are your goals? And just help them get there on their own. I mean, I know myself right out of school, I didn't know. I still don't know.
Yeah. So I'm thinking about more in a session where the client's struggling, the supervisee is, you know, counseled them, and they're now saying, wow, that's, you know, I'm not sure what happened there. I'm not sure this is what I wanted to do. Where do you go with that? How do you assist them? Like, I'll give you an example. I got a call the other day, methadone clinic. Guy came in. It was he was seen late. He had to be even later after his dose, seeing the counselor. The guy blew up on the counselor, left out and said, y'all are trying to destroy my life. Now I'm going to lose my job. You've made me late. You know, cursing, slamming the door, and leaves. And the counselor was just shocked. I mean, you know, because he didn't create that mess, right? He's at the tail end. And now he's got it to clean up. Where would you go with that? What would you do? Because he was asking me, do I pursue him? Do I call him and problem solve it? Do I just make it documented and wait to see if he comes back in? What would you advise a supervisee to do around that after a big blow up? What would you do with that supervisee?
I want to know how he was feeling.
Yeah. Yeah. Was that scary? Did you feel like, you know, what was that like for you? Yeah. And to process that a little bit. Then what would you do? What would you ask?
Document.
Yeah, document it.
Well, what's the ideal outcome that you'd like to see?
Yes, what is the ideal outcome? And his answer was, I want to see him come back and continue in the program. So how do we facilitate that? And he said, I want to call him and check it out with him. I said, do you know when he gets off work? And he said, yes, 7 tonight. So that's a nighttime call.
Just thinking about it, going back to the format that you laid out earlier, that case conceptualization of like start with strengths, what went well, what was missing, where can we improve, and then, you know, figuring out what the goal is. And then really getting ideas and planning about how to achieve that. And then reaching out and making that call. Working with the client to facilitate.
Right. And he did do that, was well received, and found out that the guy didn't realize he could come earlier. So he needed to give himself some more time to be able to make the travel to work. It was interesting because he said he first was very amenable, then he said, I'd rather be high and have a job than be on methadone and lose my job. Do you hear that? What kind of thinking is that? Very black and white thinking. And say, yes, I hear you. That tells me how frustrated you are and how important your job is to you. So let's take a look at the schedule and how we can support you to be able to get here in time, to be able to leave in time and get to your job on time. That's all it was needed. But being in an active disease process, his fight or flight, right? His trauma came up, he went into fight and then flight. And so if we're trauma-informed, we can recognize that, see that for what it is, reach out, support him to take a look at it, and say, how can I support you? I'd like to see you stay in the program if you still would like to do that.
In that scenario, I identified the value, right?
Yes.
My underlying value is I need to work.
Yes. Yeah. Identifying that value and validating that. Yeah.
What did he just say?
Go ahead, say that again.
I'm just saying, like, in that scenario, the underlying value of work being really important. You know, I'd rather be high
and have a job.
Than be on methadone and not have a job. You value your work. Being important is really important to who you are. I think that's the MI kind of way of like coming back around that, and that's what the goal is. So knowing that, how do we help you stay employed and get you methadone? Right.
And starting out, like Pam said, is helping him process the emotion first. He was very frightened. This is a big guy, and he's angry, and he's blowing out on the counselor who has no control of the system, who didn't set that whole thing up, didn't make him wait in the lobby, that particular visit, he had to see the doc. He wasn't coached that would take more time. Do you see the perfect storm that happened for a person who just wanted to come in and get his methadone and get to work, but wasn't previously informed about all the ins and outs, because he's just another methadone client that doesn't work, and we're just going to shuffle them through. And that's part of that mentality. That's the transference. And the client was the counter-transference. Yeah. And imagine if this is a brand new counselor and this is happening. I'm not so sure he would want to stay in the business very long. Right? Yeah. So really taking the time to go through this. And I was glad that he called me. He first texted me, and then I said, no, this is a phone conversation. And so we talked our way through it, and he felt comfortable and made that call. That may have lasted 10 minutes, and that may have saved a life. So really be open to your supervisees reaching out when they're really that nervous or frightened or upset with what's going on. And he advocated to the system to say, we need to let them know up front if it's going to take extra time, when they need to see the docs. That wasn't even on the clinic's radar because of that mentality of, they're just another methadone client. They're not working anyway. But the people who come in the earliest to dose are typically those that need to get to work.
And I'm thinking if you take it a step further, just imagining that he didn't get his dose, or he went to work and he got fired, and then he went home and got his gun and decided to come back to the clinic and shoot people.
Yeah, exactly.
So
it's just thinking of trying to think in my, 35 years of being a counselor and a clinical supervisor, it's forced me to look really outside the box at things that can happen. I've seen people taken hostage.
Yeah.
And I've seen counselors taken hostage. And there's counselors that get shot and killed. There's psychiatrists that get killed. So, it's that part of what we do, the intimacy that we create with people, that I think we have this tremendous amount of responsibility.
Yeah. That's a powerful statement. The intimacy we create with people carries a lot of responsibility. And if we do or say something, or the system itself shames them, it's not a good thing, because shame is so toxic and it feels hopeless and helpless. And I've tried to help myself, and look what they've done to me. And then that, it's a day and age of the gun will fix it. Yeah. And until that changes in our culture, we're at risk, because it is a population that's very volatile, and in a rural population has access to weaponry. There was a DSS worker that got pummeled horribly a few years ago. Y'all may remember that, a food stamps worker. Guy had just gotten out of prison, very antisocial. I don't remember exactly what happened, but he decompensated. And she's literally on her desk with her arms over her head while he's beating her with his fists. And finally the security got in and pulled him off. And she had permanent damage to her neck from that. And that was just food stamps. So, and that's their food. And he came in for help, and I don't remember what the issue was. I know that they run a food stamp program, and if you're a felon, you have to say that you're not using any substances. They don't do any testing or screening, but if they say, yes, I use substances or I have, they get to either go to treatment, an assessment and treatment before they get their food stamps. So they don't know to lie. And if you are honest, you don't get food stamps, and if you lie, you do. It's crazy, isn't it? Yeah. Other difficult clients. We've got about 20 minutes before we head out that door. Yes?
I have an intern who's at Monterey College.
Uh-huh.
I don't know if any of y'all know their program, so I don't have enough about it.
Is that an LPC program?
Mm-hmm.
Okay. Mm-hmm.
Yeah. So she's just started with me probably 3 months ago,
Mm-hmm.
a few months ago. And I really like her. I get along with her, so she's not a difficult intern, but she admits she just doesn't know any counseling techniques. Really at all. Like she didn't know, she hadn't heard of motivational interviewing, she never heard of mindfulness, and I just feel like starting from scratch, teaching somebody, seeing somebody every day.
Yeah.
It just seems like a lot. And it seems like when people go to other schools, they tend to know more techniques coming in and starting their internships, but I'm not sure. I'm just wanting some feedback about that.
Yeah, I mean, go ahead.
Intern from Montreat as well, and that was my same experiences. She just was about to graduate, and
So is it a generalist program or is it a clinical program? Because that makes a difference.
Okay. I'm not sure.
I know she was about to get
Well, it should be K-CREP. It's K-CREP, so they're missing something there. Oh, okay. So there it is. That K-CREP should straighten that out. But I would give the site supervisor feedback on that and say what is happening that they're coming out without the skills they need for basic CBT and, existential family counseling. Yeah.
Katie, we've had the same experience.
Okay. Well, I know with some of the Western graduates, Western's MSW program is a generalist program, and it's not a clinical program.
Right, and so you're going to see a lack of clinical there as well. And that includes Chapel Hill as well. Uh-huh.
Counseling program.
Yeah. Well, I mean, yeah, social work.
Excellent.
Yeah.
Yes, it is.
Well, and that's why many people choose Western's LPC program, because it is purely clinical, and you have labs and you come out very strong clinically. Your feet hitting the ground squarely. Lots of tapes. It's just generalist. Again, it's being aware that's the difference in curriculum. And so what I would say is start that person out on a CBT curriculum. I mean, when I was working at ADAC and I was working on my CSAC, I didn't have any counseling experience, I hadn't gotten a master's yet. And somebody handed me that curriculum and said, go after it, girl. You're going to do a psycho-ed class and you're going to do a process group. We're going to put you in with somebody who's ran process. And that's how I learned. I learned with, by experience. But, and that's how I learned about substance abuse, is with that CBT curriculum. Y'all probably remember that's when the feds came in and said, you will not be getting any more federal dollars until you treat dual diagnosis, both mental illness and substance abuse. They cleared that place out. They refurbed the whole building, all the buildings, and then hired a bunch of us BSWs, whether we ever had the CSAC or not, and we were working on our CSAC. It was crazy. But we learned a lot. Pam was a good instructor for me. And so we learned about osmosis and curriculum. So I'd say if they're going to run a group or do psycho-ed, get them a curriculum and launch them. Okay. Yeah. Good point. So you're going to do a lot more teaching, get them into some...
She's taking a motivational interviewing class tomorrow and Thursday.
Excellent. And then going over that with her, observing her, asking her how that went, practicing, role modeling, role playing. You want to quit smoking, don't you? I mean, you can pretend like you're a smoker and you want to quit and you're addicted to cigarettes. I mean, you can role play that. Yeah, figure out something you want to get rid of for real.
Too close to home.
Too close to home. Yeah. All right, good questions, good thoughts. You guys are a couple more.
Lenore Ryan's got a good program too.
Lenore Ryan, yes, their LPC program is excellent. Yeah.
I have a supervisor who is really good and really experienced.
Can you a little bit louder so everybody can hear?
I have a supervisor who's a good clinician, years of experience, knowledgeable, but I'm having trouble getting her to confront things that need to be confronted. For example, there was one of her supervisees made what she thought, and I thought too, and she told me was a racist remark.
Mm-hmm.
And it surprised me that she just didn't turn around and say something.
Mm-hmm.
And she keeps surprising me as far as what she's not saying. And to me, that's difficult because to me, she's in level 1 in that giving feedback, and she's in level 3 in everything else.
Yeah. So for her, she's obviously it's working for her and she's comfortable with it and may not have insight. So helping her have insight about how to talk with supervisees. I tend to get away from the word confront because I think that's judgmental on our part. Challenging, bringing awareness to, developing insight around, using more invitational language to say, so just want to check that out with you when I hear the statement blank, blank, blank. For me, it feels like it might have some racial connotations or gender bias or whatever. So I'm wondering where you are with that. Does anything come up for you as you hear that?
She clearly knew it had.
Okay. So you validate that. And so as you look back at that moment with that supervisee, how might you invite her to the table to take a look at that terminology or that wording and to see if that is helpful or not helpful in working with clients? Does it engage the client and connect with them, or does it create a barrier or a disconnect? Because our goal is to connect, and sometimes language can cause us to disconnect. So a lot of it's just kind of like education and conceptualization. In other words, if I say that's really racist, what happens at that moment? That can create resistance. And that's my judgment. Culturally, I mean, how many people come down from the north and they start listening to some of us and they go, whoa, you guys are prejudiced. Yeah, my husband every once in a while would say that, and I'm like, what are you talking about? He said, don't you hear your tone? Don't you hear your words? And I went, yeah, but I need to hear some more from you, obviously. Yeah. And so, again, inviting that response. Because if we confront, we get resistance. If we invite and we or challenge them to look at that in a different way. Yes?
I've had some success with, if any issue on the part of a supervisee where there's a lack of awareness that what they're doing is not being assertive enough, or is to have them view themselves on videotape. And a couple of times they've gone, oh my gosh, I didn't realize I was so passive.
Mm-hmm. Yeah. And to say, if you took that same statement and it came from a person in a group, how would you deal with that? If there were persons of color or different gender identity, how would you deal with that? Because if you don't deal with it, that person will be ostracized from the group. They won't have trust and they won't feel safe. So how might you deal with that there? And that might give you some direction on how you might deal with it with supervisees. Other thoughts about that? Comments that might sound racist or gender biased or uninviting to people that are different from the group?
I think recommending a class for cultural sensitivity and
cultural sensitivity.
Cultural studies
would
be really helpful.
Yeah.
A workshop or training.
Yeah.
People don't know what they don't know.
They don't know what they don't know. Comments like, well, he's all tatted up. What's another one I heard recently? He's all tatted up. There's another one that came to my mind. What? Yeah. He's kind of effeminate, isn't he? He's really bossy. I don't want him to come teach. I'm like, well, it's not a choice. You get us both. If you're willing to give him feedback about his bossiness, he might be able to hear it, depending on how you deliver it. In other words, to say, I don't want that person to come do trainings because he's bossy. That's between the two of them. That's not going to affect the whole agency. You kind of hear that? But he was also gay, and I wondered if that guy had trouble with him being gay.
It really pushes my buttons when people express their frustration at attempts at being manipulated maybe by clients and sort of just label clients as the others that are always lying to them or trying to pull one over on them.
Yes.
It's real kind of a broad stroke to paint.
Yeah, say more about that. So there is this mentality, this mindset that the client is less than. And they're constantly trying to manipulate me, trying to fly under the radar.
And how dare they, because I'm up here.
Yes. Or what do you do when they lie all the time? That's a classic supervisee statement. What do I do when they just lie? So they don't get that that's part of the disease process. They're not lying. That's their perspective. That's what they're coping. That's what they're doing to get by. And now we're asking for something different. So really, again, deconstructing that with that supervisee from a therapeutic perspective rather than a judgmental perspective. And even putting that on the whiteboard and looking at the difference between the languaging and the professionalism in it. Yes?
I was just going to say, I've gotten some very key things in my counseling that I learned from clients and what they had to say about me and listening to that. For example, when I was starting counseling, I was pretty passive. And then when I needed to carefront something or
carefront, I like that.
Or say no, it would be like that.
Yeah.
And a client told me that, and I, was open enough to take a look at that and balance that out. So sometimes it pays to listen to what they have to say to you.
At the end of group therapy, what did I say and do that was supportive of your process? What did I say and do that got in the way? They might just tell you.
Exactly.
They might just tell you. If you've got the relationship with them, they'll feel safe to do that.
One thing I noticed, not related but continuing with the examples, is the recovery and wellness model.
Yes.
None of that's new to us by now, or it shouldn't be. If it is, I hope you will move into real estate or something, because it's not okay anymore. So, 10 to 15 years, we've been talking about recovery and wellness models versus disease or moral models, etc. And so, just even in this room, and I mean, I'm not pointing fingers at all. I've been guilty of it myself, but I've heard the words. The labeling, I heard somebody say so-and-so had a personality disorder, and then I heard the label. Somebody was a personality disorder. So it's just semantics.
So we want to say with a personality. Yeah.
I heard that. So we label people, not jars. Or label jars, not people.
I'm following you.
I don't feel good. And then also, I've heard the word crazy.
Yeah.
Around quite a bit, and that's just an example. And language is the way that we shape our culture.
Yes.
So even in this group of us, clinical supervisory style professionals, it's still going on. So it's still pervading our worlds, and I think just bringing awareness to it, saying that we're all guilty of it. Let's do our due diligence, just that, an inch or two more, and take it back to our agencies and see if we can be pervasive with that language and really not tolerate it, and gently call each other out when we hear it.
They're cray-cray.
Don't say that.
Yeah, I mean, that's really, I mean, in a lot of agencies, that's.
Oh, you're being serious.
Yeah, no, they're actually, I mean, that's a term. They're cray-cray.
No, I know it's a term, but it's very.
And so what does it mean when we say that? And we don't have to say, don't say that. We can say, so when you say that, tell me more about what that means to you when you're sharing about that client. Because if we're not careful, we feed the negative language. Like, I don't hang out with people crazier than me. I don't mean that to be a professional statement. I mean that's a personal kind of thought that I need to be around stable people. And if they're not real stable and I'm not in a therapeutic relationship, I've got a choice that they're going to stress me out, and I might just stress them out because it's a mutual stressing. So again, languaging is hugely important. There's a new piece that kind of came up a few sessions ago, classes ago that I was doing here, is how many people still say drug of choice? And so what's the jury say about drug of choice now? It's drug of addiction, primary substance. Why do we not say drug of choice anymore? It's not a choice. It's what their brain chooses that for them that makes them feel better. It's a biochemical disease process. And so when we say drug of choice, and it alludes to a voluntary choice. And that's a big leap. Boy, you start getting to old AA and NA and you say that and they're like, what now? Oh my God. Have y'all had that reaction? Woo! Or bring that up to a supervisee that's in recovery or from the old school. It's like, okay, so let's unpack that. You know, I could react and go, whoa, you better get with it. And I get resistance. But say, wow, you had a real strong reaction to that. So tell me what comes up for you when you hear me say that. Oh, wait a minute, that sounds like therapy. Oh, David Powell was right. Sometimes it will sound like therapy. And you got a choice whether to unpack that and explore that with a supervisee or push back and get resistance, and then you both leave stressed out. So there's a lot of choices, a lot of options. I thank you for the examples that you brought to the table today, your experience, your heart, and that you will go out there and do a stellar job and a loving job with your supervisees and clients.